Hello, Dr. Ching. Ashish, am I audible to you people? Dr. Ching, Dr. Ashish.
Yeah,
Abri,
very
am
much,
I
Ullas.
audible to you?
Yes, very much. We are with
Ashish,
you.
welcome. Ashish, can you hear me?
Thanks. Yes, very much. We are with you. Are you able to hear me?
I can't hear you, Ashish. I don't know.
Uh-huh. One second.
Dr. Ching, can you see me? Can you hear me?
Yes, I hear you loud and clear.
Oh.
Greetings.
I can't hear for some reason.
Singapore.
Can you hear me, Ullas?
Start all over again.
Ashish, can you hear me?
I can hear you.
Some glitch here.
Can you hear me? Hello, can you hear me now?
I hear you loud and clear.
Okay, thank you. Always nice to have you, Dr. Ching, on the panel.
The pleasure is mine. Thank you for this invitation.
You just through with your work at the hospital, Dr. Ching?
No, it's a Saturday, so we
Yeah.
I have no clinical duty, so I had a session with the medical student this morning.
Oh, wow.
We did an ECG Jeopardy for the medical students.
Good. That's great. These are the medical students or the ones doing cardiology or internal medicine.
Yeah, these are the medical students from 3 medical schools in Singapore. We had a
wow.
ECG competition among the final year medical students. It was fun.
Yes,
It
absolutely.
was a fun way of teaching.
No, I think we are okay. Right at the time. I'm okay. There is some technical glitch. Ashish, say hello to me.
Yeah, hi, Ullas. We are with you.
Dr. Ching, how glad I am to have you on this forum.
The pleasure is mine, Ullas. It's always great to work with you.
Okay, ladies and gentlemen, it's 4 o'clock and there were some technical glitches. I was a little worried whether I'll be seen or I'll be heard. But you people always make me heard and make me feel proud. So this is the 4th annual online EP Fellow Summit, and I welcome all of you heartily. This EP Fellows Summit, which is online, it provides a platform to the young electrophysiologists to share their work, to share their cases, presentations with the faculty known for their passion for educating the young electrophysiologists. They are all distinguished. Today we have a galaxy of moderators, and I'm sure all the presenters will feel happy and proud of presenting their cases. I would like to just share today's program. So we have Ashish. Can you hear me?
Yes, very well. And your
And then,
slides
you
are
know,
also
this
seen.
program
Yes.
is seen here on the screen. Yeah. Is it seen? My slide is seen, Ashish.
Yes, very much.
All right. So thank
Good
you.
to go.
Ashish. Yeah. So now, today we have a galaxy of moderators, and on behalf of my colleagues in India, who is the consultant in EP department here, and my director Ajit, I welcome you all. There was an overwhelming response from the young electrophysiologists, not only from India, across the seas. There were 43 submissions, and we could select only 26, just because the time was not permitting to take. All of them deserve to be presenting. And this is the galaxy of the moderators who are known for their accomplished work. Ashish, Dr. Ching is already here. Anil Saxena will be joining. Raja, Krishna Kumar, Suchit Mujumdar, Vivek Chaturvedi, and Debabrata, Abhishek from USA, Amit Ora, Shomu, Nitish, and Malini from USA, Deep, and Avinash. They are going to be moderating these lucky presenters. And day two, again, there is another list of illustrious electrophysiologists. And then there are these presenters whose work, as we go through their work, we will understand what is the passion they have, and with what hard work they had put in to present these cases. And there are 13 presenters for the day today, and another 13 presenters for the second session. And let's start with Dr. Surampalli Vijay, who is going to be talking on RBB morphology, wide QRS tachycardia, what is the mechanism? And Anil Saxena, I think, is going to be joining, but Ashish and Dr. Ching, grateful to you that you made your time out. And then you may start inviting Dr. Surampalli and then start the discussion. Surampalli, I think you are ready.
Sure. So these are recorded presentations, or they're going to present live, Ullas?
It depends whether if they're online, it is there, or if they are not online, their recorded presentations will be.
Okay, so Vijay is
I
online.
will see. I will see
Yes,
how it is coming up.
Hi,
Yeah.
hi, sir.
Hi, Vijay. You can start.
Good evening, sir. Yes.
Saran, you can start the presentation.
Yes, sir. I'm sharing my PPT, sir.
Okay.
Sir, are my slides visible, sir?
Yes,
Yeah.
very much.
Yes.
And my voice is also clear, sir, right, sir?
Yes,
That's
yes.
right.
Yes, yes, sir. So, good evening and warm welcome to one and all. First of all, I would like to thank Ulla sir and yes sir for giving this wonderful opportunity to present my case in this great platform. And my case is RBB morphology, wide QRS tachycardia, and what is the mechanism. So my case is a 35 years old man who presented with rapid paroxysmal palpitations due to wide QRS tachycardia for 1 year, and of which one episode was terminated with an adenosine, and he's having a structurally normal heart. So this was the ECG, tachycardia ECG, which is wide QRS tachycardia, which is showing monomorphic R wave, that is atypical RBB morphology, with a negative QRS in 2-3, with a biphasic QRS in AVR, that is left axis around minus 60 degrees. So atypical RBB with left axis QRS of minus 60 degrees, with a positive concordance in the chest leads, and there is a broad QRS at the base. So these are all, and there is no clear-cut evidence of AV dissociation. So after seeing this wide QRS tachycardia, the differentials we considered were antidromic AVRT, and ventricular tachycardia likely from the inferior posterior area. And this patient actually was cardioverted from the periphery center and was referred to us. Of course, this is not a immediate post-cardioversion ECG, but the baseline ECG was this, which was essentially normal without any clear-cut evidence of pre-excitation. So in a patient with wide QRS tachycardia, if the baseline ECG shows there is a manifest pre-excitation, then we can it gives a clue that the wide QRS tachycardia likely due to antidromic tachycardia. But here there is no pre-excitation, but that does not rule out the antidromic tachycardia as a mechanism of tachycardia, because at baseline there may not be a pre-excitation, especially in the left-sided pathways, it depending on the conduction properties of the AV node as well as the pathway. But in view of engaged structurally normal heart with adenosine responsive tachycardia, we thought was the antidromic tachycardia as a first possibility rather than VT. So then we subjected him for an EP study, which showed baseline the AH and HV intervals are normal, and the tachycardia was repeatedly easily inducible with the ventricular extra stimulus. With the first extra stimulus, there is an VA conduction. With the retrograde, A was the earliest in his proximal. With the second ventricular extra stimulus, we can easily appreciate the retrograde his followed by A, and the VA conduction is delayed. That means it is a decremental VA conduction. Of course, it's not a programmed ventricular stimulus, and this is followed by initiation of the tachycardia with a VAV. VAV mechanism, of course, this rules out atrial tachycardia as the mechanism of tachycardia, but anyway, this was not the differential diagnosis in our case. And one more important thing to consider during the tachycardia is there is a proper hiss during the sinus rhythm as well as during the second ventricular extra stimulus, but there is no hiss because it is buried within the QRS. So basically, it is a negative HV tachycardia. The differentials again are antidromic tachycardia, AVRT, as well as myocardial ventricular tachycardia. So this will not help in ruling out these two. During the tachycardia, we gave adenosine, so that terminated the tachycardia after an A wave. So this also more in favor of tachycardia mechanism as an antidromic tachycardia rather than myocardial VT, because myocardial VT won't respond with the adenosine. And if at all, if it is a antidromic tachycardia, the pathway can be adenosine responsive. That may be the atypical pathway. And again, we tried atrial pacing. During atrial pacing, we gave the adenosine. Again, there was no pre-excitation. There is an AV block. So it can be due to either both AV nodal as well as the pathway block because of the adenosine responsiveness of the pathway. So next, during the tachycardia, we tried entraining the tachycardia through the atrial ordinary pacing. The tachycardia is going on at a cycle length of 300 milliseconds, negative H tachycardia. And we tried doing atrial ordinary pacing, and it entered the tachycardia during the atrial pacing cycle length of 270 milliseconds. With a concealed fusion, there was no change in the QRS morphology. And later at 250 milliseconds, there is a termination of the tachycardia. After that, the atrial pacing has been conducted through the AV node, AHV. So during wide QRS tachycardia, atrial overdrive pacing enter in the tachycardia and later terminate the tachycardia. This will happen only with the SVT, but not with the myocardial VT. Of course, the fascicular VTs can enter in with the atrial overdrive pacing, but negative HV tachycardia and adenosine responsiveness of the tachycardia rules out the fascicular VT also. So to confirm this, we gave a late atrial extra stimulus during the tachycardia. This late atrial extra stimulus terminated the tachycardia abruptly without any QRS. This confirms that the atrium is the part of the circuit. And one more additional atrial extra stimulus, which does not terminate the tachycardia, but it delays the next A by around 40 milliseconds. It delayed the next QRS by 40 milliseconds. That means it delays the next A by 40 milliseconds. This is called post-excitation. So this prolongation of AV and delays the next QRS, proves the participation of antegrade accessory pathway during the tachycardia. So this is antidromic AVRT, likely due to adenosine responsive antegrade conducting pathway, likely left-sided Mahim pathway. So again, we put a decapolar catheter into the LV, and we tried pacing through the LV, but there is no retrograde conduction through the pathway. That means it is only antegrade conducting pathway. And during the tachycardia, if you see the earliest V was clearly observed in the LV1 and 2, likely near the CS34. So we tried pacing from CS34, probably likely from the pathway. But interestingly, there was no manifest pre-excitation even when we paced the left atrium through the coronary sinus from C34. So during the we mapped during the tachycardia through the retrograde transaortic route, just near the mitral annulus, near the CS34, we can clearly observe the earliest V signals around preceded the QRS by around 30 milliseconds with a good negative QS complex in the unipolar. In this area, left posterolateral, likely from the left posterolateral under the mitral annulus. So the RF energy terminated the tachycardia in an antegrade direction after an A wave. That means it eliminated the pathway. So the final diagnosis is, or in our case, is antidromic AVRT due to left posterolateral Maham's-like accessory pathway. So the learning objectives are Maham's accessory paths are typically right-sided, but left-sided pathways are not that uncommon. In a study by Gormel S. et al., who studied the anatomical localization of Maham's accessory pathways, 7.3% of them were ablated in the mitral annular region. And majority of the left-sided Mahim pathways are clustered in the left lateral mitral annular region. And from the literature, I could find two big studies, one from China of their decades experience, and in one more study from 2015 to 2020, retrospectively, they collected the cases of Mahim pathways. Out of around 2,300 patients, they found only 13 cases of right-sided pathways and left-sided are 4. And out of 251, one more study, out of 251 patients, right-sided pathways are 8 and left-sided pathways are 4. They compared the electrophysiological characteristics of right and left-sided Mahim accessory pathways, and they found that left-sided Mahim accessory pathways are rare, and the left-sided Mahim accessory pathways are atrioventricular, that is short when compared with the atriofascicular pathways on the right. And out of in all these 8 cases, they couldn't find even in single patient, they found the M potentials, unlike the right-sided pathways. Thank you.
Yeah, over to the moderators. Welcome, Dr. Anil Saxena, Yash Lokandawala.
Thank you. Thank you.
Yeah, thank you, Dr. Vijay. That was a very nice case. Just a few questions. In the atrial stimulation study, were you able to observe during the atrial extra stimulus technique whether there's any pre-excitation when the AV interval prolongs?
No, sir. Actually, we couldn't find any pre-excitation even during when we pace near the pathway also, sir. Actually.
Okay. What about when you deliver atrial extra stimulus technique, which means you deliberately cause a delay in the AV node such that you facilitate conduction via the accessory pathway, whether you have observed any of that phenomenon?
So sir, one more thing is like during the tachycardia, when we paced from the CS34, it entered in the tachycardia. That means probably during the tachycardia, the AV node is already involved in the tachycardia, so it is refractory. Probably that may be the reason it might have conducted, but not during the baseline sinus rhythm, sir.
All right. I mean, thank you. It's very clear that it's a ART involving a decremental accessory pathway on the left side. Nice presentation.
Yeah, which I am
Yes,
also impressed by your presentation, especially that atrial extra stimulus prolonging uh, and providing antegrade conduction by the pathway. Did you induce the tachycardia anytime without a VA conduction given during ventricular pacing? That would have said it's a VT, right? So I guess every time you had to conduct VA before you induce the tachycardia.
yes, sir. Yes, sir. It's always through the AV node, retrograde conduction through the AV node, and then initiating the tachycardia. Sir. It's
Other thing
always.
is usually we record a Mayan potential and we are ablating more on the atrial side when you're doing the right side. So
Yes, sir.
had you done a transeptal puncture and tried to ablate on the atrial side? Would you have recorded a M potential? I mean,
No, sir. Actually,
your literature search must have been retrospective to say that others did not record. But
yes.
you could have hoped to record if you tried to map on the atrial side when you are ablating. Is that possible?
Yes, yes, sir. Actually, we didn't do that. Actually, we might have done transeptal puncture and we might have paced near the pathway to whether to confirm that it's an antegrade conduction is there or not. And during the, as you said, during the mapping also, it might have showed the M potential. We couldn't do that, sir. Actually, we didn't do that.
And I do not understand why you wouldn't pre-excite when you are pacing in the coronary sinus 3-4.
Yes, sir. Actually, that the reason maybe there is an isolation between the pathway and the CS, sir. That's what we thought. Or there is a very sluggish conduction, or there is a conduction delay between the CS and the pathway. That's why whenever we pace from the CS, there is no pre-excitation even near the CS pathway when we pace.
Any anatomical abnormality of the mitral valve?
No, sir. Structurally normal heart, sir. Mitral valve is normal, completely.
Anil, over to you.
Yeah, I actually joined in between the case, but I think a very nice case, and I think I have nothing more to add. Good presentation as well. Appreciate it.
Thank you, sir. Thank you.
Ashish, if you permit, the master is around.
Oh, yeah, sure.
Ash is around.
Yeah, you want to.
So Ashish, I knew that this question would be coming, and it was a pertinent question. Why could we not pre-excite by pacing the atrium? And as we probably had a transeptal in place, by pacing the atrium, if we could show that the CS activation was not close to the, like it was, if you're pacing close to CS3-4, but yet the CS activation was concentric, 9-10 earlier than 3-4, that would have proved that there's a severe conduction delay between the atrial insertion of the accessory pathway and the Mahan pathway and the coronary sinus. So that was one really point, but we had already taken a trans-aortic route, already fully heparinized the patient. And this was actually Aditya Kapoor's case in SGPGI Lucknow. So yeah, but scientifically, I think we could have paced the atrium near the left atrium and tried to show pre-excitation, at the same time tried to show a conduction delay. As Vijay said, during tachycardia, when we could entrain, the AV node was refracted because it was antidromic tachycardia, and therefore during tachycardia we could entrain showing that it was not a complete conduction block, but possibly a severe conduction delay between the coronary sinus and the atrial insertion site of the accessory path.
Sure. Thanks, Yash. Should we move on?
One request from the master. How many times you have had this the fortune of getting left-sided Mahem kind of an accessory pathway, Dr. Yash?
This is my third. In my experience, this is the third case. Very rare.
Yeah. Ashish?
Sure. No, I haven't had any, but I know Yash had reported one previously. Sure.
Is around?
In my experience, I've seen one
Okay.
so far. It's very rare.
Such a rare case. And that is why we thought we should be starting off with such a rare case and then performed by the candidate, and the master is Yash. So are there any questions, Ashish, you are seeing in the comment box? I don't think so.
Yeah.
So Dr. Yash and your candidate, congratulations. You deserve to be presenting first, Dr. Yash.
Thanks.
Thank you.
Next case, please.
Thanks.
Thank you, sir. Thank you.
Since we have gone through those cases, we really know that the next one is equally challenging, and Dr. Ching, we have to be sitting upright to take this one on. Dr. Bish, you can come along with your presentation. Is that recorded or is he live? I think
Sir, it is recorded.
Okay, so I think Dr. Bisht is around, but we can play the recording, right?
Yes, yes, sir. I think my voice is not playing there.
Can hear you, but yeah, your recording doesn't have your voice. That's
Yeah,
true. You have to restart it or.
Yeah, so can we restart and then you go on commenting on that, those traces? David, is that okay?
Dr. Bisht,
David,
can you?
as your traces come along, will you give a commentary?
Dr. Bisht, you are able to hear us?
yes, sir, I can hear you, sir, but I won't be able to comment because I'm in a moving car. And if you give me some 10-15 minutes, I will.
Okay, so now we'll
we can-
postpone your presentation.
We take the third one, Ullas?
Yes.
No,
Take the next one.
can you hear me? Can we postpone his presentation according to his convenience if the moderators agree?
Yeah, sure. I think we can have.
Yeah. So, Saran, you be in touch with him when he's ready. You can get his. So go to the third presentation, Saran.
Sir, we will be sharing his recording again, sir, like right now.
Okay, fair.
Okay.
Greetings, one and all, and thank you organizers for this opportunity. So my case is a conventional SVT case that is having some good observations. So case is a 60-year-old gentleman who was suffering with recurrent PSVT for several years. He was having normal echocardiogram and taken for the EP study. The baseline ECG doesn't show any pre-excitation and normal PR interval. Intracardiac electrograms were having normal AH and HV interval. They started with the program stimulation. The RV pacing demonstrated the decremental VA conduction with VA Vanky-Back cycle length of 320 millisecond. Also notable was the earliest retrograde A that was recorded in the proximal CS electrograms. Catheter manipulation easily induced the clinical tachycardia that was a narrow complex tachycardia with septal VA interval of 135 millisecond. Earliest retrograde A was recorded in the proximal CS electrodes, and there is a variability in the AH and HA interval that leads to variability in the tachycardia cycle length, and tachycardia cycle length would vary between 330 to 390 milliseconds. To differentiate the mechanism of tachycardia, we started with the different maneuvers. Ventricular overdrive pacing demonstrated a VAHV response and PPI minus TCL of 170 millisecond and SA minus VA of 160 millisecond. This observation most likely seen in cases of AV and RT. It was a reproducible and consistent response. However, we induced another response in which the first return beat was having a broad QRS and his activation was from distal to proximal. So this broad QRS beat could be explained by two mechanisms. One, it could be the PVC beat, and second, it could be a pathway beat. So however, we cannot exclude totally that it is not a PVC, but PVC is less likely because the local V in the RV electrodes is later than the His electrodes. So likely this beat is a pathway beat, and if this is a pathway beat and it is a pre-excited, then it should be totally pre-excited because it cannot fuse with the antigrade conduction from the His because His was refractory from the previous beat. So if this is a pre-excitation, then it should be totally pre-excited. Looking at the morphology of this pre-excited beat, it is having a left bundle morphology and leftward axis, likely suggesting a atriofascicular connection to the right ventricle. It could be a nodofasciculoventricular pathway that is that could be considered. However, it is a non-reproducible response and was not seen in the subsequent VOPs. The hissing PVC did not reset the tachycardia, but a early hiss PVC pulled the retrograde A and retrograde H and reset the tachycardia. Burst pacing from the proximal CS channel lead to the QRS fusion, that you can witness in the surface ECG, that there are two wavefronts that are consequently fusing with decrease in the cycle length, and at the end of pacing there was a tachycardia that was started. So to summarize the observation, what we have seen, that tachycardia was a narrow complex tachycardia with earliest retrograde A from the proximal CS electrodes. Tachycardia cycle length would vary between 330 to 390 millisecond, and during tachycardia there was a variable AH and HA interval. VOP response, one is a favorable that favors the nodal response that was reproducible and consistent, and there was another response that suggests a pathway, and it was a non-reproducible response. The PVC response during tachycardia, the hissing PVC didn't reset the tachycardia, but a early PVC lead to the resetting of the tachycardia. Atrial pacing showed a QRS fusion that suggests a pathway. So based on this observation, the atrial tachycardia was excluded because we had demonstrated the consistent VA linking, and differential diagnosis left were atypical AV-NRT versus the ORT via the decremental pathway. To further differentiate between these two diagnoses, we shift back to the basic, the first slide. If you look carefully, the first slide, the oscillation in AH interval creates a subsequent oscillation in the HA interval. If you look at the HA interval of this beat is markedly broader than the HA interval of the subsequent beat. And subsequently, the AH interval of this beat is markedly narrower than the AH interval of this beat. So the oscillations in the AH interval lead to oscillation in the HA interval. And after an initial AH prolongation over the 3 beats, the cycle repeats itself for the next 3 beats. So there is some kind of group beating that has been described in the Banky-Beck phenomena for the nodal AV block. And in the same way, this oscillation creates an irregularity in the intracardiac and surface electrograms. So likely the His and A are not part of the circuits, and we are measuring the nearby structure, and the driver is somewhere else. That can be explained by the AV-NRT, in which the driver is in the AV node, and His and rest of the atria are activating parallelly, and we are measuring the pseudo intervals and lead to the seeing this variability. In the few cycles, the HH interval is constant. Only the AH and HA is variables, because His is the closest structure to the AV node. So this explains that His is least affected by the variability, but rest of the atria are affected by the variability. More likely, it supports that the atypical AV-NRT involving a bystander pathway, and decrement is most likely at the lower common pathway. Just to exclude that it is unlikely that this tachycardia is AORT, it is just a hypothesis that because the earliest retrograde A was recorded from the proximal CS. So when we pace the proximal CS channel, and if we consider that the tachycardia starts much earlier when we stop the pacing, and in the last few beats, we actually entrain the tachycardia. And if we look at the post-pacing interval from the CS electrodes, the post-pacing interval is 520 millisecond. And if we correct it by the prolongation in the AH interval, it it is 80 millisecond, and the tachycardia cycle length is 380 millisecond. So if we took this measurement, it comes out to be 60 millisecond. That is, the proximal CS electrodes are away from the circuit. So it is just a hypothesis that this is unlikely that the tachycardia is ORT, but a atypical AVNRT. So based on this observation, we considered the patient for slow pathway modification, and we did the slow pathway modification with the help of non-irrigated catheter using 50 watts, 60 degrees, and we get good junctional rhythms. In few of the junctions, we get a concentric pattern of in the CS electrodes, and in the few of the beats, we found a eccentric activation. So this eccentric activation can be explained by the bystander pathway, and this junctional beats gives a pseudo reassurance for the safe ones, because we may be damaging the fast pathway and getting a retrograde A by the pathway. So we should be careful when dealing the slow pathway modification in the setting of bystander pathway. So after successful slow pathway modification, we again did the program stimulation on isoproterenol and induced the second tachycardia, that is a non-sustained orthodromic reentry, in which the CS activation is eccentric and distal CS electrodes were having early A compared to the proximal electrodes. Although we cannot be assured at this point that our decapolar is in the proper position, it may have displaced. That could be one explanation of this change in CS activation. After that, we did the program stimulation, and the RV pacing also demonstrated a eccentric VA conduction that confirmed that there is a pathway. And during RV overdrive pacing, in the last beat, you can see that this beat doesn't conduct, this beat conducted through the pathway, and the last beat is conduct, because the pathway was blocked, it was conducted through the node. So there are two limbs for retrograde conduction. One is through the node and another through the pathway. Initially, we are getting the retrograde conduction from the node, but after slow pathway modification, we are conducting retrogradely via the pathway. After looking at this observation, we considered for pathway ablation and took a septal puncture and targeted the pathway antegradely, used a irrigated catheter, 35 watts, 43 degrees. And you can see when we push our decapolar more distally in the CS is showing a unique kind of activation in which both V and A are fused. If you go back, you are seeing a different kind of activation. Possibly at this point of time, our decapolar were touching the floor of the CS and getting this kind of pattern. And in the previous tachycardia electrograms, our decapolar was more proximal and touching the roof of the CS. So the two wall of the CS were showing different kind of activation. So after localizing the pathway, we ablated the pathway, and there is a gradual local VA separation. And afterwards, we did a program stimulation on isoproterenol, and there is a consistent VA dissociation. We checked on high doses of isopril. There was no tachycardia that could be induced. Previously, the tachycardia was induced on catheter stimulation, and afterwards, it was no longer inducible on high doses of isopril. So take-home points are, during sinus rhythm, the time it takes for signals to travel from the atrium to his and from his bundle to ventricle reflect the true interval between these sites. But during AV and RT, the interval measured may show the relative activation time between these two locations and known as pseudo intervals. In cases of AV and RT, despite the His bundle's proximity to the arrhythmia circuit, it remains distinct from the circuit, and oscillation in AH and HA interval will not affect the circuit itself. And the extended lower common pathway was possibly the cause of variable intracardiac intervals during the clinical tachycardia. That was atypical AV and RT in our case. Thank you for patient listening.
Dr. Bisht, the presentations of your kind is what makes the CP Fellows Summit to really be recognized. It was a wonderful presentation. Let me not speak because
Thank you.
I think the words are to be spoken by Anil Saxena. I am seeing him, how enamored he is about your presentation. Ashish and
Absolutely.
King are still there. This is one of the best of the EP cases I have heard, and then I'm fortunate to witness. Dr. Saxena.
Thank you, sir.
Very, very nice presentation and very nicely explained everything. One point, Dr. Devan.
Yes, sir.
Where was your CS? Was it very much out, so that the earliest A was very distal in the distal CS, and then it became very proximal, kind of totally changed from completely eccentric to completely, concentric.
Yes, sir. Yeah. Actually, sir, previously, because I was just checking the recorded version of the fluoroscopy. And this case was done around 5 months back. So I'm not very aware what was the position of my
Alright, so
CS.
maybe it was
But
completely out at that time.
yeah, so possibly you are telling what it is absolutely correct, because in previous fluoroscopy images, my CS catheter was near the os. But in the later, when I was doing the pathway ablation, I deliberately inserted the decapolar deep inside the CS to bracket the pathway. That's why the CS is showing different kind of activation.
Dr. Bisht, if I have to play the devil's advocate, in one of your first ECG of narrow QRS tachycardia, there was at least one beat which had a distal to proximal kind of a atrial activation in the CS, where when I went prospectively through your presentation, I thought that's a little fishy. But I guess you can't replay that slide set. So not. I have only one question for you in this way, is that when you said it's a atypical AVNRT, when you ablate and get the junction rhythm, why do they still show a V on A pattern and not the same retrograde atrial activation as from an atypical AVNRT you would suspect? Why do they look like the A on B kind of junction rhythms only? Do you have some kind of explanation for that, or any from the moderators?
Sir, actually, I was ablating in the setting of a bystander pathway. So that's why in the initial few burns, my pathway was the retrograde conduction is through the fast pathway. And in few of the burns, the retrograde conduction is through the bystander pathway. This is possibly one explanation.
So you had an atypical AVNRT, right?
You might have shifted to entirely on pathway.
You had a slightly longer VA, so it's atypical AVNRT is what you are proposing. But the junction beats look like a typical AVNRT kind of a slow pathway ablation. That's my question. Is there some explanation for that?
So only explanation is that the pathway doesn't involve the clinical tachycardia is not involving the fast pathway. It is involving the slow kind of circuit, because the exact circuit of AVNRT has not been understood till now. And what we are measuring is actually the pseudo intervals. So that is one possible explanation from my side.
And when the AH and HA intervals are varying, can you still validate your VOP in the same way?
It is difficult to validate, but if we can correct the delta AH, then it is definitely in the favor of AVNRT, because PPI minus TCL is too long. It is 170 millisecond. And even if you correct it with the AH interval, it will be still more than 115.
Sure.
115.
Yes, thank you. It's a very nice case. I think in the slide where you shows tachycardia with a septal VA of 135 milliseconds and above, and you show and measured there were variable AH and HA intervals. I think we could observe that when the tachycardia cycle length shortens to 320 milliseconds, the VA actually shortens, and the atrial activation on the CS changes from a proximal to an eccentric atrial activation. I think when you see that, it's a suggestion of a bystander pathway. I do agree that when you convincingly and reproducibly shows the intervals to be atypical AV nRT, we will go for the slow AV nodal pathway ablation. Just get one variable out of the way and then study the next variable. A very nice case. My question for you would be, why did the eccentric VA conduction becomes apparent after slow AV nodal ablation? What are your thoughts on that?
Possibly, sir, it is changes the refractory period. If I have ablated at that area, it may have changed the refractory period. That's why it is more conducible for the eccentric pathway activation. And if after I induce the non-sustained ORT, when I did the again VOP from the right ventricle, it was preferentially conducting through the pathway, and when the pathway is blocking, it was conducting through the node. Previously, it was opposite. Previously, the pathway was AV node was conducting, and pathway was not apparent at that in the initial VOP. But after slow pathway modification, the VOP from the pathway is more apparent, and AV node is later.
I think that's an excellent observation that the ERP for the accessory pathway is slightly longer than the ERP for your slow AV nodal pathway, and hence you're able to conduct via the AV nodal pathway and sustain an atypical AV nRT. That's number one. I think that's the most common explanation. The others in the literature suggest a source sink mismatch. I think that remains in a bench setting and a bench observation. And lastly would be some electrotonic, what we call modulation. And after an ablation, it causes the nearby pathway to be facilitated. And I think one last would be the anisotropic nature of the AV nodal pathway versus the accessory pathway. For example, in an atypical AV nRT, the activation is from proximal CS, to the distal CS, and that direction may not facilitate activation via the pathway. The anisotropic nature and conduction of accessory pathway. So my congratulations, and a very interesting case. Demonstrates two tachycardias with some clues in the initial tachycardia, but shows a very pragmatic approach. We get rid of one variable and then study the other variable. Congratulations.
Thank you very much.
Thank you, Devendra. And Ashish, Dr. Cheng Saxena, your comments were commendable. But I think the gentleman Devendra Bish is the rising star. The way he analyzed, is exemplary. Okay, now
thank you,
Devendra, congratulations.
Thank you.
So we'll invite Dr. Ananda Pasula, who was also trained here in our center, and he's going to talk about some troubles which are multiple, I believe. So, Anil and Ching and Ashish, you are staying back to moderate his session too. This is a live presentation.
Good evening, sir.
Yeah, okay, go ahead.
Are my slides visible?
Yes.
So at the outset, I would like to thank my mentor, Dr. Abdullah sir, for giving me this opportunity. So today I'm going to present a case where we had a double trouble. So myself, Dr. Anand, and I'm practicing as an electrophysiologist in Kim's Hospital, Andhra Pradesh. So coming to the case presentation, we had a 58-year-old male with recurrent palpitations since 5 years. ECG showed wide complex tachycardia. Echo showed a structurally normal heart, and the patient had a diabetes and hypertension. So this is a presentation ECG, and the tachycardia has a spontaneous termination. Actually, the patient went to the nearby hospital where this was documented. So it's a RBBB type quite with precordial concordance is there. And so here, axis is AVR positive. So this is the tachycardia had a spontaneous termination. So this is the one of the baseline ECGs which has shown the positive delta 1 and negative delta in AVL. So there is no negative delta in lead 1 also. So all this suggests to a left-sided pathway. So clinically, we made a diagnosis of WPW syndrome, antidromic AVRT, probably a left-sided accessory pathway with intermittent pre-existing. In between, patient used to have a normal ECGs also and good LV function. So coming to the basal intervals. So AH was 60 and HV was 45 because the pre-excitation was intermittent. So when we have taken the patient onto the table, we had only normal P. There was no pre-excitation. So we started ventricular pacing. Ventricular burst pacing induced the tachycardia. So there was a retrograde VA conduction from that leads to antegrade nodal conduction, then initiated the orthodromic tachycardia, orthodromic AVRT, okay, with the earliest in the CS digital. So tachycardia characteristics are induced by V burst pacing, and it was a narrow complex tachycardia. Atrial activation sequence has showed earliest activation is a CS digital. So it suggests to of orthodromic AVRT, left-sided pathway. So we did ventricular extra pacing. So the extra beat, when we paced at the 500 drive train with the 350 extra stimulus. So initially VA was very short. With the extra stimulus, the VA has prolonged. Probably earlier it was predominantly by pathway. So then it was predominantly by the node. So it has triggered a on V tachycardia antegradely through the probably slow pathway and retrogradely to the fast pathway. So this is now it induced ventricular extra stimulus pacing induced A and V tachycardia with short VA. So his synchronous PVC was given. It did not affect the next A and B. Ventricular overdrive pacing has shown that TPA minus TCL was more than 115, and stimulus to SA minus VA was more than 85. So the second tachycardia characteristics are, it was induced by ventricular extra stimulus pacing, and it was a narrow complex tachycardia with tachycardia cycle length of 470 milliseconds. It was A and V tachycardia with short VA less than 70 milliseconds, antegradely slow pathway and retrogradely through the fast AV nodal pathway. Hissing PVC did not affect the next year. So ventricular overdrive pacing has shown the PPM minus TCL more than 115 milliseconds and SAVA more than 85 milliseconds. All these suggest of typical AVNRT. So we try to overdrive the AVNRT to terminate the tachycardia. So during atrial overdrive pacing, so it was ANV tachycardia. Then once we started the atrial overdrive pacing, there was a shortening of HV interval, and it triggered and it induced the another tachycardia, which has shown the pre-excitation and a short H. So this was the clinical tachycardia with which patient was presented to the hospital. So this tachycardia also shown the earliest activation in the CS disease. So finally, the EP study characteristics are wide complex tachycardia, antidromic AVRT, left lateral pathway. So in this patient, we had both orthodromic AVRT initially, then AVNRT, then during overdrive pacing, antidromic AVRT through the left lateral pathway. So transeptal access was taken for this patient, and we could not get the proper pathway potential, but we have given the wherever the A and V are fused and the suspected pathway potential was there, then we could do radio frequency ablation, but there was no VA suppression and tachycardia continued to be induced. So as we failed endocardially, we tried the epicardial axis. So we need to go high coronary sinus, almost near to the left atrial appendage. So before giving ablation, we have taken the coronary shot also. There was no any coronary artery nearby to the ablation catheter location. So we could able to find a good A and V fuse signal with suspected pathway potential. With the single one, the patient there was a VS depression and the loss of free excitation. So later on, we ablated the AV nodal pathway also for AV and RT. So post RFA, there was no pre-excitation. There was no induction of any tachycardia, both with or without isopropyl. So this is the three things. We have done open window mapping for the pathway. So this is the site where we have given ablation for the pathway, and this is the site where we have given the ablation for the AVNR. So final diagnosis: WPW syndrome, SVT with antidromic AVRT, dual tachycardia induced during EP study. So there was a AVRT and AVNRT. Successful ablation of left lateral pathway and modification of AV nodal flow pathway. So from my case, deep negative delta wave in AVL was seen in our ECG, which suggests an epicardial pathway, probably near the atrial appendage. Coexistence of more than one SVT are not uncommon. Most common coexisting SVTs are AVNRT and AF. Ventricular pacing inducing typical AVNRT is very rare. Usually, ventricular pacing will not induce AVNRT. If at all it induces, more commonly it induces atypical AVNRT. Pathways can conduct in bidirectional way. Sometimes same pathway can induce both orthodromic and antidromic AVRT. Coronary sinus is an alternate route for epicardial ablation. Thank you.
Great case, Anand. And over to the moderators.
Yeah, hi. Very nice presentation. I would have, may I ask you a question? Do you go retrograde ever? I mean, I would have gone retrograde because you can go under the valve and look at the ventricular side of pathway insertion before going, before considering epicardial approach.
Most of the time, I will be comfortable with the transseptal accessor, and it will give more catheter stability for me. And I'm comfortable with the transseptal accessor.
No, Anand, the question here is same. I would have asked is that yes, you are comfortable with the transseptal approach and you made enough attempts on the atrial side, but then obviously before taking the step of going epicardial, did you map by retrograde transaortic approach under the valve, or in fact even did you map deep in the coronary sinus to understand how the location is before you did the epicardial? I'm sure you must have done before taking the step to go epicardial. Am I right or wrong?
I mapped in the coronary sinus, but was not done through the coronary sinus. Mapping through the coronary sinus.
Sure, Dr. Ching.
Yes, Dr. Anand, excellent case. I just want to find out, was the patient given isoprenaline during the procedure?
Post ablation we have given, sir, not before the ablation, because tachycardia was easily inducible. Either it is a AVRT or AVNRT.
I see. And the other thing was the patient adequately sedated during the procedure? I ask this because it's very interesting. You're able to maintain retrograde nodal activation, and hence you can induce AVNRT. You're able to maintain the retrograde nodal activation very well, and hence you can also induce ART because you need to have the nodal retrograde component. So I just thought maybe he was given good doses of isoprenaline. If it's not, maybe his the sympathetic drive was high and able to maintain. But nonetheless, a very good case. As to where shall we ablate this, transseptal is okay, retrograde aortic is okay, and if both approaches can't get the pathway, epicardial via the CS is also okay, because these are all suitable sites or suitable approaches to ablate epicardial accessory pathways nonetheless. And the recent Heart Rhythm Journal have a special section on pulse field ablation, and they were reported cases where point by point pulse field ablation within the CS abolish accessory pathway ablation. I mean, if that works consistently, that would be an amazing way or technique, and that would change the way we do ablation on the left side of the heart. Thank you very much. Excellent case.
One other point of interest is that in many patients with dual tachycardia, the AV-NRT is the non-clinical tachycardia. A lot of people have dual AV nodal physiology and they may have inducible AV-NRT. They never have clinical AV-NRT. And the clinical tachycardia must have been AV-RT. I mean, like in this case, in many cases.
I think all in all, a wonderful session, especially for the youngsters where you probably must decide to take these wide QRS tachycardias to the lab because not every time they are a VT. When structurally normal heart, obviously it becomes that much simple. But we have had instances where the so-called coronary artery disease and things like that, and you automatically shouldn't decide that's a VT. There are ECG features which could be misleading, and two wonderful first and the last presentation where the wide QRS tachycardias. In fact, in the first, the pre-excitation was not apparent, so makes it a little more challenging even than the third one. So enjoyed the whole set of presentations.
So Ashish, it is your comments, it's your presence makes all these young electrophysiologists be inspired in presenting. And Dr. Ching, I entirely agree with you. The PFA is going to change the way we are going to be ablating this regular tachycardia. I'm not talking about AF, but PFA is going to armor us much better, and then we will be able to provide safer ablation lesions. I think so. Anil Saxena sir, you agree with me. We have started off this summit in a great style, great presentations, and Saxena ji, Nabar ji, and Cheng and Yasha also was there. A wonderful first session. So we move forward to the session 2 now. Then I welcome Raja Seluraja, the great academician who is the head of the Department of Electrophysiology, Pacing Department at JIPMAR, Sujit Mujumdar, my great friend, who is going to be organizing the IHRS 2024 annual conference, Krishna Kumar Mohan Nair. I think he's the most published electrophysiologist in the country today. And of course, my dear friend Vivek Chaturvedi. They are going to be the chairpersons, and let's invite Anish Bhargav. And he's going to be talking about atypical presentation of adult onset permanent PJRT. Lot of confusion. People ask me, what is the long form of PJRT? All right, welcome, Anish.
Good evening, sir. So my screen is visible, sir?
Yes, sir.
So good evening, sirs. So I am Dr. Anish Bhargav, a second-year fellow in cardiac electrophysiology and pacing under the guidance of Professor Raja Selvaraj in JIPMAR. So coming to my case, so our case is a 24 years old female who is a nurse by profession, who was incidentally detected to have an abnormal ECG during pre-employment checkup, and she was referred with this abnormal ECG to us for further evaluation of the rhythm. And the echo was done at the time of presentation, showed a structurally normal heart with a LV ejection fraction of 60%. So this was the ECG at the time of presentation, wherein we can see that she is having basically an abnormal rhythm, which is going on at a rate of around 85 beats per minute with inverted P waves in inferior leads and a long RP interval with a single upright sinus P wave, and the termination of this rhythm with the P wave followed by spontaneous reinitiation. So this is the sinus P wave that I was talking about, and it is followed by a first bit of tachycardia, which is a negative P in lead 2, and as we can see with that subsequent, it is different from the subsequent P waves of the rhythm, and this rhythm terminates with a P wave, which is inverted in lead 2, followed by a next sinus beat and the resumption of the same tachycardia. So what are the possibilities at this point of time with the long RP tachycardia? So the first is, could it be a atrial tachycardia? So coming to this point, we can see that there is a short runs of this ECG is basically showing a short runs of tachycardia with a consistent termination with the P wave. So AT is basically supposed, like when AT terminates, it is supposed that the last bit of AT should conduct to the ventricle. So it is very unlikely that the AT terminated and at the same time it encountered a AV block. So that makes AT unlikely. It can happen coincidentally, but not in a consistent basis and is not reproducible. So that makes AT unlikely. So what could be the other possibilities? So it could be a atypical AVNRT or a PJRT. However, we can see that here the tachycardia is getting initiated in the sinus rhythm without the need of any time premature atrial contractions, followed by a spontaneous termination and again reinitiation again following a sinus beat. So this makes atypical AVNRT unlikely, and this is basically very typical of a PJRT. So this is the rhythm strip up, and we can understand what is happening in this rhythm strip by way of this ladder diagram, wherein the first beat we can see that it's a sinus beat, and the atrial activity after starting from the sinus node conducts down the AV node to reach the ventricle, which then conducts retrogradely through the accessory pathway to reach the atrium. So by the time it reaches the atrium, the sinus node has already fired, and the first beat of tachycardia that we are seeing, which is different from the subsequent P wave, is basically a fusion beat, as is marked up in the ECG as F. So followed by a subsequent P wave that are basically having a consistent negative P wave morphology, and the termination of the termination of this rhythm with the P, which that basically encounters a block at the level of AV node, which fails to conduct to the ventricle. And the next bit that comes up is the sinus beat, and followed by the same sequence of events thereafter. So to better characterize the P wave morphology and the tachycardia, we also did the Holter in these patients, and we can see the same phenomenon repeating in the Holter, except the fact that the first beat now is the pure tachycardia P wave without any fusion, because at other points of time when the sinus rate is a little bit relatively slow, so that this fusion phenomenon is not there. And but here also we can see that there is the initiation of tachycardia during the sinus rhythm, and with the consistent with the termination with the P wave. So this again points toward the fact that we are dealing with the PJRT. So with this differentials in mind, we we took the patient for the electrophysiology study, and this is the baseline intracardiac electrogram that the patient was having at the beginning of the study. And on the right hand side, we can see the fluoroscopy image. We have used 4 catheters, one quad each in atrium, ventricle, and decapolar in CS, and the arrow marks the location of the CS 910, which is at the CS os, and the one mapping catheter, which in this fluoro image is at the level of Hess. So we can see that the first beat is the sinus beat, and which conducts down through the Hess to reach the CS 910 and then other electrodes. So it takes around 50 milliseconds for the impulse to travel from HRA to CS 910. And in the second beat, we can see that there is a slight change in atrial activation sequence, wherein the earliest atrial activation is still in the HRA, but CS 910 has moved in by around, and at the same time has now reduced to 22 milliseconds, suggesting that there is a fusion of activity from the sinus beat as well as the tachycardia beat, as is also evident from the surface P wave morphology, which is different from the sinus as well as the subsequent tachycardia beat. And the third beat is basically a pure tachycardia beat, where there is earliest atrial activation in CS 910 with a negative P wave in ABF. So this tachycardia initiation during the sinus rhythm is the typical feature of a PJRT, which we were also seeing on the ECG previously. So this is the intracardiac electrogram during the tachycardia, wherein we can see that the tachycardia is going on at a rate of around 660 milliseconds with a VA interval of 463 milliseconds. It's basically a long VA interval, long RP tachycardia, with earliest atrial activation in CS 910 and with 1:1 AV conduction. So then we began with the maneuvers, and here we had began with the Hess refractory PVC. So this is the Hess refractory PVC that we delivered. As we can see with the fusion kind of QRS morphology and the timing of the PVC that matches with the Hess. And we can see that the tachycardia, which was going on at a rate of 660 milliseconds, with the delivery of this Hess refractory PVC, the next atrial activation got delayed by around 26 milliseconds, and the tachycardia continued with the similar atrial activation sequence. So these two features, basically Hess refractory PVC delaying the next atrial activation as well as the continuation of tachycardia with the similar atrial activation, points towards the fact that there is a presence of decrementally retrogradely conducting slow pathway, which is also taking part in the mechanism of the tachycardia. And this makes basically the possibility of AT and AV and RT unlikely. So we continued with the His refractory PVC, and here again we can see that with the delivery of the next His refractory PVC, the tachycardia terminated, and it fails to tachycardia terminate without being able to reach the atrium. So this again is a typical feature of a PJRT, wherein the His refractory PVC terminates the tachycardia without reaching the atrium. These two features proves that we are indeed dealing with a PJRT. So what is the diagnosis that we have by EP study by now? So we have a slowly conducting concealed posteroseptal accessory pathway presenting to us as a orthodromic incessant long RP tachycardia, which is basically a permanent junctional reciprocating tachycardia. So with this diagnosis in mind, we began mapping for the tachycardia, mapping for the earliest atrial activation during the tachycardia. As the yellow arrow points out, this is the site where we got the best signals below the CS os, which was around 40 to 50 milliseconds ahead of the surface P wave onset. And these are the corresponding 3D 3D images, wherein we can see that these are the RAO and left lateral image of the activation map. So we began mapping for the during the tachycardia for the earliest atrial activation by setting the window of interest, wherein the onset of window we have set at around 100 milliseconds ahead of the surface P wave onset, and the end of window was at the QRS onset. And CS7 was taken as a reference. So with these settings, we did an activation map, and we could find the earliest atrial activation, as pointed out here by the white arrow, was below the CS os at around 5 o'clock position of the tricuspid annulus. So when we were sure about the point of interest, we began delivering the radio frequency energy. And here we can also see that at the best site, we were getting, and in the unipolar channel, we can see that we are getting the predominant QS signals, which also points out to the fact that we are probably at the best site. So we began delivering the radio frequency energy, and by the third beat, we can see that there is a termination of the tachycardia with a VA block, so that the last QRS fails to reach the atrium, followed by the next sinus beat and the resumption of the sinus rhythm, and during which we continued the radio frequency energy for the total duration of 60 seconds. So this was the post after the ablation, wherein we can see that this patient is having a sinus rhythm with a rate of around 75 beats per minute with a normal PR QRS axis and without any STT changes. So what are the peculiar features of this case? So first of all, this it's basically an adult onset. She presented in at the age of around 24 years. She was currently 24 years. So PJRT has been known to be commonly present in the age group of like infants and children, and as such, the adult onset presentation is quite uncommon. So, and secondly, even if they present during the adulthood, so by the time they present during the adulthood, there is a persistent tachycardia, and by the time they present during the adulthood, they become symptomatic. So it is very rare for this patient to be asymptomatic till adulthood. And because of the persistent tachycardia, this patient usually developed a tachycardia-induced cardiomyopathy and the symptoms related with this, with the tachycardia-induced cardiomyopathy. So this lady was basically having a structurally normal heart with a completely normal LV ejection fraction. So coming to the final diagnosis, so she was basically asymptomatic with a concealed right posteroseptal accessory pathway with a slow and decremental conduction presenting as orthodromic near incessant tachycardia, which is basically a PJRT. So we decided ablation in this case because of the two reasons.
Yes,
so the reasons were twofold. The first was the patient concern regarding like because of this abnormal rhythm, she was not getting any employment anywhere. So she wanted to get rid of this abnormal ECG rhythm. But we were more concerned about other facts that if we let the tachycardia to continue like this patient runs the risk of tachycardia-induced cardiomyopathy. And we know that medical therapy is, especially in adults, it is ineffective. So as such, we went ahead with the catheter ablation and did successfully ablated the pathway. So coming to the follow-up, see, by now it is almost around 3 months and the patient is doing well, is asymptomatic, and the last ECG that we did was showing a sinus rhythm. So thank you.
Great case, Anish. Rare case of an adult onset PGRT, and your mentor has joined us. Thank you, all the moderators. Raja, I think you are joining us. Raja is the one of the most wonderful teachers, and then Anish, you must be very lucky to be trained by him. Raja, you have some comments. Suchit also had joined. He's one of the moderators today, and my friend Vivek is also around. Great case. It's a rare case. Vivek, you can take up first. Vivek, can you hear me? Raja, you can give some commentary about your case.
Yeah, I thought one, like you said, is a little relative rarity, and also it was a good way to illustrate all the maneuvers, and it's as good as a teaching case. So I really thought, I mean, it's our case. So if there are others who want to have who have any
So
comments,
I know our Suchit and Suchit had joined. Chaturvedi had joined. You people.
Yeah, Suchit is unmuted now. So Suchit, you wanted.
I joined a bit late because I thought the time. So that's why I was not commenting. So I saw the
Suchit,
ablation.
Suchit, you must have received his presentation, right?
Maybe yes. I've not gone through it. Probably that is
No
my
problem.
fault.
Vivek is around. Vivek.
I'm around, but I could join only very late. I thought starting at 5:30. That's what I was told, and I'm still in the OPD.
Yeah,
I saw that you are running early.
Sorry.
Unusual of any one of the conferences. I know. But Vivek, you must have also gone through his presentation.
I had just started looking at it, but
Don't worry. I think you know what? The greatest of the teachers. Please, Raja, you give the commentary, please. You give your own remarks, please. It's a great case, all the
like I said,
and in fact, even during the so-called sinus rhythm down the note, there were subtle changes with the A to the CS. That kind of an observation is an astute observation.
Yeah, I think the ECG was also interesting as a teaching ECG to differentiate atrial tachycardia from others, and then all the intracardiac, especially you can see how useful his refractory PVCs are because they really clinch the diagnosis. Once you have a his refractory PVC altering the atrial timing in any way, really all other differential diagnoses are out. So I think that was the primary thing of the case. I think there was a comment.
Okay, I also am seeing that comment.
Let's see.
No, but atypical AV versus PGRT, sinus cycles slowing before tachycardia initiation. Yeah, I mean, yeah. So,
here we had really single beats of sinus rhythm, so we can't really see a sinus cycling. But I think just the initiation in sinus rhythm without any premature beats itself strongly favors PGRT, because that is where it's you don't really need an extra stimulus to come and block in one of the antegrade pathways, and tachycardia can just initiate in sinus rhythm. I think that was seen in this case.
So I have a question to you, Raja. When do we suspect PGRT in the clinical scenario? I mean, either they are the young or the old.
Yeah, I think like Anish said, the typical clinical presentation is a child who comes with incessant long RP tachycardia and has LV dysfunction. Here we had like you said, near incessant, because it would terminate and then there is single beats of sinus rhythm where it reinitiates, but long RP tachycardia with inverted P waves in the inferior leads. And here the termination with P waves was very consistent, repeatedly happening, which goes against the diagnosis of AT, because she was diagnosed as atrial tachycardia in a couple of places outside. So that tells us this is not atrial tachycardia. Otherwise, I think we still keep a possibility of atypical AVNRT going into the case, but still that initiation in sinus rhythm was also strongly favoring PGRT here. So this is not the typical setting to suspect otherwise.
What appears to be like a persistent sinus tachycardia in the clinical practice, especially in young, I think we should also suspect it could be PGRT. You agree?
So, sir, can I make a small comment? So, from this ECG, the VA interval was shortening from the first time. So, when there was sinus beat, the VA which was coming, and then during the tachy, it was shortening. What can be the reason for that?
Okay, so now can you put up that presentation, please? So
I
that we
don't
can
think
go
there
back.
was significant change, but if there is change, it is still understandable because these pathways are decremental. So,
But why it is changing in the opposite direction when the rate is increasing?
Now,
so
which is the
here,
slide
if
you would like to have?
okay,
No, the sinus, then there is a beat, fast
Yep.
beat. Now, if we think the fast PGRT beat is that, then there is a problem. Otherwise, if we think there's an ectopic, then it's fine.
no, from the first beat is re-entry, but like you're saying, from the first VA is longer and then the VA slowly gets shorter. That's what you're saying, right?
Yes.
Yeah. So I think
No,
might-
because if the rate is increasing, the VA should prolong if it is a decremental. That is my question.
so
Means there is some active, maybe some effect of the other pathways or something on that electrotonic something.
maybe like AV node, you get kind of accommodation where once it conducts over a series of beats, it's gradually decreasing.
No, AV
And
node
then-
is same actually. What is decreasing is the
No, I'm
VA.
saying in AV node, sometimes you see this at the initiation, the AH is long and then the AH accommodates with further beats of tachycardia.
Yes.
Maybe behaving in a similar way. That
So is there? I don't know. That was my question. Whether this pathway
no,
behaves like
it's
that.
a good observation. I mean, good
Yeah,
observation.
absolutely.
But it definitely, the pathway conduction time is longer in the first couple of beats and then shortens as it goes on. Yeah.
Yeah, it is decremental. It is decremental, all right. But during acceleration, it also kind of improves, I believe.
So that is another point.
Absolutely. It's a great observation. So
Yeah, can I make a comment here?
Please.
Yeah, so I
Is this
just happened to
Karthikeya?
look through.
Is this
So there is,
Karthikeya?
it's a fantastic case.
Oh,
Also,
okay.
the two beats with his refractive PVCs, they have different morphology implying fusion. Again, implies a atrioventricular re-entry circuit.
You want to bring back that trace?
So there are two his refractive
PVCs, Anish.
Okay, go. Next slide. Next. Yes, this is the one.
So look at the morphology of the his refractive PVC here and in the next slide.
Next.
Yeah, the next one is a little more premature, which terminates.
Correct. So what I'm saying is
More
that this
fusion
kind
here.
of a fusion also probably implies again that this is different from a fully RV paced beat. This is probably some amount of fusion is there.
Yeah, this beat and especially the previous one, it's very clear from the ECG itself that it's his refractory. You don't need timings. You can see based on the ECG morphology. Yeah.
Correct.
So is the last beat fast beat of PGRT? Where is it now in the intracardiac?
Yes. That is also showing.
Activation pattern is a bit different. That's why I was telling.
Maybe slight fusion. AVF is still upright. Looks still
No,
mostly
intracardiac.
Okay. It could be that reinitiating again after the sinus beat because the atrial activation sequence is slightly different. Yes.
Slight fusion.
No, so I think there is a APC. So that's why we cannot put that VA and the other VA sign. That was my point. Maybe.
So Vivek, any more final comments?
No, that's it. Thank you.
Wonderful. So Suchit, Vivek, thank you for joining. Raja, great case, unusual case, and Anish, well done.
Thank you, sir. Thank you.
So I think Suchit, Vivek, and Raja, you please stay back. There are two more presentations coming up. Now we have a redo SVT by Indrajit Devnath. Welcome, Indrajit.
Please start your presentation.
Sir, I'm looking for the presentation slides. Hello. Can you share my slide? So my slides visible, sir?
No, actually, I think
Not
they
yet.
will send it. They'll send it. They'll send it. I think there's a technical glitch. I apologize. Just hang on for a while. I think it will be all set.
Okay, sir.
Dr. Indra, just give us a time.
Okay, sir. Okay, sir. Sure, sir.
Maybe the network is slow. Saran, is this a problem or?
So is the presentation slide visible now?
Yeah, partly, not very clearly on my screen at least.
All right, so we'll be sharing it again.
That's much better.
All right.
That's much better. Yeah. Sorry. Okay, carry on, Indrajit. Sorry for this. Carry on. Indrajit, are you around?
Please start your presentation.
Dr. Indrajit, can you hear us?
I guess somebody else can project for him while he can speak.
They are projected, but I think he is not available now. He's got disconnected.
Let's go to the next presentation, please.
Okay. So can we move on to the next presentation?
Yes, please. We can come back to this once he's there.
Good evening to all faculty. Can you see my slides, sir?
Yeah, we can see them.
So thank you for this opportunity to present an EP case. I'm a senior resident from JIPMER, and my case is a tale of two tachycardias. So our patient is a 49-year-old male, known diabetic and hypertensive, who presented with 3 episodes of sudden onset palpitations in the last 6 months. And he also has history of dizziness, and the palpitations were once reverted with diltiazem. Echo showed a structurally normal heart. So his baseline ECG was otherwise normal, the sinus rhythm and PR interval of 160 milliseconds with no delta, and QRS duration of 80 milliseconds with a normal QRS axis. So we had 2 tachycardia ECGs for this particular patient, and the 2 were slightly different. So we'll be seeing each one of those. So this is the first tachycardia ECG. It showed a regular narrow QRS tachycardia at 180 beats per minute, which had a short RP and the RP interval was about 80 milliseconds, as we can see somewhat clearly in AVF. And there was also an R prime in V1. So this actually looked very sharp to be a retrograde P wave, but this was not very clear at this point. But there's no QRS alternance and no prominent tested depressions or T wave inversions. This was this other tachycardia ECG with a slightly slower rate of about 160 beats per minute. Again, short RP with a slightly longer RP interval of about 100 milliseconds. And this showed a clear-cut QRS alternance, which was somewhat atypical because QRS alternance should ideally be present with the faster tachycardia. So here we can clearly see the QRS alternance in leads V2 and V3. So we proceeded with the EP study. These were his baseline characteristics, and the intervals were otherwise normal with a cycle length of 560 and normal PR, AH, and HV intervals, and no obvious pre-excitation in the sinus rhythm. So we proceeded with ventricular extrastimulus pacing. We got a consistent 1:1 retrograde conduction, which was concentric, and it was decremental, as we can see here with the faster premature complex, which decrements the conduction. So there was a decremental concentric 1:1 consistent retrograde VA conduction with the earliest atrial activation in the HIS. On atrial burst pacing, we got a PR of a PR interval that was more than the RR interval, as can be seen here. And there was consistent 1:1 AV conduction, suggestive of a dual AV nodal physiology. When we proceeded with atrial extrastimulus pacing on a atrial double extrastimulus, we got 2 beats of AV nodal echo. So we had a non-sustained AV NRT. And keep in mind the cycle length here, it was 260 milliseconds, and the atrial activation, which was atrial activation sequence here. So the cycle length is 260 and with a VA interval of 20 milliseconds. Also, we can note that it is spontaneously terminating with a A. Another atrial double extrastimulus then induced the tachycardia, but clearly we can see here that the tachycardia, this tachycardia is different from the one that from the ill-sustained AVNRT that we just saw. So here the VA sequence, that the atrial activation sequence is eccentric with the earliest atrial activation happening in the CS. The cycle length was also slightly shorter at 320 slightly longer, sorry, with a cycle length of 320 milliseconds, and the VA interval was 78 milliseconds. So when we compare the 12 lead ECGs of these two different tachycardias, actually we didn't see that there was too much difference in the QRS morphology. Although the AVNRT was faster, otherwise the QRS morphology was pretty similar between the two tachycardias, but there was a clear retrograde P wave that we could see in the AVRT tachycardia. So we proceeded with ventricular overdrive pacing, and here we see that our first 2 beats of ventricular overdrive pacing, there is some degree of fusion, but the first fully paced beat actually pulls in the A and entrains the tachycardia. On stopping the ventricular overdrive pacing, we had continuation of the tachycardia with the VAV response, which rules out atrial tachycardia, and the eccentric activation sequence, which ruled out an AVNRT. So we got a diagnosis of a concealed left lateral accessory pathway with sustained orthodromic AVRT and dual AV nodal physiology with non-sustained AVNRT. So we did a transeptal puncture. Also, we did LV pacing for this patient. Here we can see the first few paced beats from the LV, and the last few paced beats are from the RV. And clearly we can see the atrial activation sequence, that is the VA conduction. It is eccentric in the first few beats and concentric in the other beats. So we mapped the pathway with LV pacing, and we found a VA fusion with the pathway potential at about 3 to 4 o'clock position. And we ablated this pathway at this point. So it ablated within the 5th beat of pacing. And we got a clear local VA separation here. So, but even after this ablation, we could persistently induce 2 beats of AVNRT. So slow pathway ablation was also done. After ablating both the pathways, we had a normal cycle length normal PR, AH, and HV intervals. There was no pre-excitation. There was no retrograde eccentric VA conduction from the LV and the RV pacing. There was no PR more than RR. No AH jump, which was not there before as well. And the VA conduction was 1:1, central and decremental. There was no inducible tachycardia. We had a concealed left lateral accessory pathway with inducible orthodromic AVRT, a dual AV nodal physiology with inducible typical AVNRT, and a successful ablation of both the pathways. Here there were some subtle differences in the two tachycardia ECGs, which could point to the possibility of two different mechanisms. Although in our case, the faster tachycardia is, we're still not sure whether it could be AVNRT or since the VA was also borderline, like about 80 milliseconds in the tachycardia. And LV pacing can be helpful to characterize and map a left lateral pathway. Also, the QRS alternance that we got in this case was somewhat atypically present in the slower tachycardia compared to the faster one. Thank you.
Thank you. A wonderful case. Over to the moderators, please.
Okay, so can I make a comment, please?
Yes,
please.
Yes.
Yeah. So if you look at your sinus rhythm ECG, first of all, am I audible?
Yes, sir.
Yeah, Vivek.
Yeah. So see, fun thing is that I don't know how many Dr. Raja, I think, has much more experience that, but whenever I see a large R wave in V1, which is almost equal to S wave, that itself makes me think that, this is somehow pointing towards a diagnosis of an accessory pathway. This is something which has been described, but it is not really very specific, although it may be sensitive, but it's not specific. So it may be similarly loss of septal Q waves. Also, although here in V6 there was a septal Q wave. Now, if you look at your tachycardia 1, then there is clear cut, you can make out inverted P waves in lead 2, 3 AVA, which are away from R wave. So it's not a pseudo S there.
Yes, sir. Yes, sir.
And
So
if you
the
need to,
VA interval that we mentioned was 80.
Yeah.
We didn't the RP interval that we mentioned was 80. So we didn't
Correct.
count the pseudo, we didn't count it as a pseudo R wave actually.
Yeah, and then as you mentioned correctly, that the pseudo R in V1 is really too short
Yes, sir.
for the 80 interval you said. Now, if you look at the tachycardia 2, that has the same morphology as a sinus ECG.
Yes, sir.
So my question to you is that why do you need to invoke AV and RT for this? I mean, why can't this be just because you never could really get a AV and RT going? Is that true or no?
Yes, sir. It was not sustained, but even with the we could multiple times we could induce 2 beats of AVNRT, 2 beats of AV nodal echo. That is yes, sir. But it could not. It was not sustained. Yes, sir.
So Vivek, I think good point in the sense first that pre-excitation from a left lateral pathway can be very subtle, and one of the signs to look for in the ECG is early precordial transition, which we noticed in this case. But this patient finally did not have any antegrade conduction through the left-sided pathway, so it was a concealed pathway. So here it's not related to actually pre-excitation. And then we cannot say for sure whether, of course, these two ECGs are the same tachycardia or they are two different tachycardias. But based on everything, we thought that these are probably two different mechanisms, and that and even though in the lab we could induce only 2 beats of AVNRT, that we thought one of these ECGs represents a sustained AVNRT, and therefore we decided to do a slow pathway ablation. If it was a single echo, we would have.
Yeah, I'm completely sure that your decision was fine.
Yeah.
But if you can go to that slide comparison of the 12 ECGs of 2 tachycardias.
Right.
Yeah. So here, even in the sinus rhythm, you are getting that R dash kind of a thing.
Yeah.
In the first ECG. So so definitely this was not a pseudo R pattern, but yes, there could be two tachycardias, as you mentioned, right? There could be a AVNRT which was there, but and especially because the cycle length is different. But when you say that there was no pre-excitation, did you also pace near the pathway? Because sometimes if it's quite left-sided pathway, sometimes can not get pre-excited if you pace them from rightish sides?
Yeah.
Yes, sir.
Yeah, sometimes may not, but I think we're fairly sure there's no pre-excitation.
Okay.
Yeah, we have to check from
Yeah.
CS spacing on this.
Right. Okay. Fantastic case otherwise. Thank you.
Thank
Suchit,
you.
you have any comments?
I think no, it's discussion is good actually. So AVNRT was not induced, but definitely there is a slow pathway, and sometimes this slow pathway can induce another AVRT also by a decrement. So anyway, we have got rid of that.
Yeah, it's a relatively straightforward case. I think the only main thing, one of the interesting things was, I mean, one is that we had two different ECGs clinically. And even though we say QRS alternance is a rate dependent phenomenon, actually we had alternance with the slower tachycardia and it was not there with the faster tachycardia, which we think is here suggests that the alternance is more dependent on the mechanism than the rate. And then this patient, until we induced tachycardia, we never saw eccentric atrial activation. So we didn't see conduction through the left-sided pathway at all unless we induced tachycardia. So that is again something not very common but can happen. And when that happens, again, this utility of placing an LV lead instead of mapping during tachycardia where things may be very unstable, we can use an LV lead, place it close to the ventricular insertion of the pathway and use V pacing to map. But otherwise, I think it's a relatively straightforward case.
Good learning points actually.
Can the presenter just show, for the sake of the fellows, the ablation of the left atrial pathway, the EGMs there? What I would like to, for the fellows to concentrate here is the phenomenal pathway potential which is there.
Just go back one slide before. Yeah, you can see here actually very nice pathway potential. You can see
beautiful pathway potential.
Yeah.
And this is something which we should all strive. And Dr. Raja is an expert in this, obviously. But this is just a phenomenal pathway potential. Absolutely beautiful.
So, Saran, are we going to invite the next case?
Yes, sir, we are ready.
Yeah, so I think there was some technical glitch with Dr. Indrajit's presentation. So, Raja, wonderful going on here. Suchit, stay back. Vivek, we're going to hear Indrajit's presentation. There was some technical glitch. He's talking about some redo SVT, is that right? Indrajit,
Yes,
you unmute, please.
Yeah, that was us.
Dr. Ching, thank you so very much for staying back.
Please share my slide.
So, I think we are seeing your presentation. Indrajit, can you start?
Yes, sir.
Please start.
Yes, sir. Good evening, all. Next slide, please. This is a case of redo SVT. So, this is a case, a 44-year-old man with history of recurrent palpitation. He had similar history of palpitation episode last 2 years on and off. And he had a documented narrow QRS tachycardia, which was responsive to adenosine. The same patient had history of left posterior accessory pathway ablation from LA in another center around 6 months back. But no records of EGM are available now. And echo revealed a structurally normal heart. Next slide, please. So we can see in the baseline, this is the baseline ECG. You can see that the PR is interval is short and there is some pre-excitation. And if we apply the Aruda algorithm, we can see that V1 is positive delta. So we directly go to lead 1. We directly go to V1 where we can see this R is more than S, and from this we can assume that the pathway is somewhere near the left sided. And in the AVF we can see another negative delta, so it is mostly and the pathway is mostly lying in the left posterior region. Next slide. So patient was taken up to the EP lab, and these are the baseline characteristics. So we can see the pre-excitation clearly here, and this is the AH interval, which is around 83, and we can see the very short HV interval, which is around 8 milliseconds. So which also suggests that there is presence of some accessory pathway. Next slide. Next, please. Next. Okay. So from the above electrograms, we are sure that there are presence of some accessory pathway. So we try to pace the ventricle, and here we can see this is the 8 this train of 8, this is the 8S1, and which is followed by S2, and this train of 8 was 450 millisecond, and with a short followed by a short coupling interval of 310 millisecond. And we can see here that the conduction from ventricle is ventricle to atrium is going retrogradely. So there is a retrograde pathway. There is a retrograde conduction.
Completely drunk.
Hello, sir.
Carry on.
Continue.
Okay. So VA conduction is present, and it is earliest at around, we can see here, it is around CS78. Okay. So we can see that the interval between the timing between the ventricular pacing stimulus and the earliest atrial electrogram in S1 beat is this interval, and the interval between the S2 and the VA, and these are both are same. So we can say that it is a non-decremental VA conduction. And similarly, we can see that at around 250 coupling interval of extra beat, there is still VA conduction. And from this electrogram, we can assume that we can see that the retrograde ERP of the pathway is around less than 210 milliseconds. Next slide. So next, we have given some atrial extra, and there is activation of the pathway, and earliest activation is around V678, and at around extra of 230 millisecond also, it is conducting in this anterogradely, and we have achieved the atrial effective refractory period of at 210. So we can assume that this is an antegrade accessory pathway effective refractory period is less than 230 milliseconds, which also signifies that this is a very fast conducting accessory pathway. Next slide. So from the above, so the earlier electrograms, we are sure that there was presence of accessory pathway. Now we have to make out whether the accessory pathway is a part of tachycardia or not. So induction was done by ventricular atrial pacing, and we can see that the narrow QRS complex tachycardia at a cycle length of 310 milliseconds. The earliest atrial activation is around 7-8. Next slide. So ventricular entrainment. Also, we can see you press on the next, please. And two more. Okay. So we can see that entrainment. This is the post pacing interval of 382 millisecond and a cycle length of 317. So if we subtract this, this difference comes out to be 65 millisecond, which is less than 115 millisecond, and which also signifies that this is the accessory presence of accessory pathway. And in this, we can also see that entrainment occurred or entrained at the very fast fusion beat. If you see, this is the fusion beat, and you can see this duration is much smaller than this one. So it has been entrained in the very first fusion beat. So all these features are suggestive of orthodromic AVRT. Next slide, please. So our EP diagnosis is manifest left posterior accessory pathway and pathway characteristic high risk pathway, because these are these pathways are very high fast conducting and indivisible AVRT. So before moving on to mapping and ablation, we kept in mind two things in our mind, that this is already a case of failed AVRT and failed ablation, and also that we are dealing with a posterior pathway. So upfront we have decided to take a CS angiogram in order to see whether there is any abnormality related to coronary sinus. Next slide, please. So this is a liver phase angiogram. Next, please, you play this one. We can see that there is some diverticulum like thing appearing at the CS opening or near the CS opening at around the opening of the middle cardiac vein. Next slide. So here this is a still picture. So we can see that there is some diverticulum, and it is not unusual that we get a accessory pathway related to the coronary sinus when we are dealing with left posterior pathway. And also we have I have not shown the angiogram. We took the coronary angiography before because we are dealing with this area, so we need to be careful regarding the PLV branch of the RCA. Next slide, please. So what is the ablation tactics are? Irrigated catheter, power 25 watt, 45 degrees centigrade. Target, we need to target the neck of diverticulum to look for CS muscular potential. Ablation from LA is often unsuccessful. So it is sometimes better to put two decapolar catheter in the CS, one along the roof and one along the floor. And in epicardial CS related accessory pathway, floor A will be earlier than the roof. And in our case also we got the same. Please, next slide. So here we can see that these are the pathway potential. We can see here pathway potential. I'm not sure whether my cursor is visible to you or not. But we can see in the ablation catheter there is pathway potential, and similarly here pathway potential. And after this ablation was done, that we can see that there are loss of pre-excitation and the atrial and ventricular signals got separated. So we are sure that probably the pathway got ablated. Next slide. So this is how a catheter in the neck of diverticulum looks like in the areocranial view on the left hand side. On the right hand side, you can see this in diverticulum in LO view. Next slide, please. Next. But we can see that some retrograde persisted, and we had to map again near the neck and higher up. We can see that these are the potential which are atrial and ventricular are not being separated. So we had to ablate this area also by next slide. So we can see some good potentials here, and which we could ablate within 2 seconds. We could clearly ablate, and both antegrade and retrograde conductions are absent now, and the pathway is almost ablated. Next slide, please. So these are my last slide. So this was the last slide, and the take-home message is that if we had to deal with the posterior pathway, we should not we should also think about the coronary sinus abnormality, and we should also look for before this is more easier than going to the left side of the atrium and ablating. And probably this was initially when ablation was done 6 months back. Probably they did it from the left side, or so probably they missed the pathway.
All right, Dr. Indrajit, a wonderful case. Certain new things here. Mapping with the 2 decapolar catheters in the CS, looking for not only the abolition of the antegrade conduction properties, but you should look for the retrograde properties. Great case. Over to the moderators.
Okay, so yes, very nice.
Yeah, Vivek.
So
Sorry, Vivek.
I want to thank Sujit Majumdar sir for helping with the case, sir.
Sujit, you must be around, please.
Yeah, I am around only. I think he has discussed, so
Sujit
let's
helps all of
others.
us.
Yes.
Hello?
So I was saying Sujit helps all of us actually.
Of
So
course.
No, nothing like that.
yeah, so beautiful case as usual. And couple of things for the fellows. First of all, the sharp negative delta in lead to almost like a QS pattern. That obviously is one of the signs of epicardial. Not very sensitive, but once you find it, it is quite specific. So can you show that ECG again so that people can have a look?
Yeah, can you show the first ECG? Yeah.
Yeah. Also, whenever you present Dr. Indrajit, then probably it's also
Yes,
a good
sir.
idea. It's also a good idea to show this ECG in when it is fully pre-excited. So that is always a good idea, because sometimes in this area, things change. And sometimes there are more than one pathways, and you can see the shifts in QRS with that. The other thing,
Okay, sir.
obviously, is very true what you pointed out, one about the CS, the other point being sometimes you can find that the retrograde and antegrade conduction are not gone at the same place. And probably, there can be a broad sheet, but more importantly, I think sometimes here, and Dr. Raja, I think, can also comment on this. Sometimes, the CS musculature acts as a go-between between the atrium and the ventricle here. So that is
Yes,
why
sir.
you may actually get a different retrograde and antegrade routes here. So and obviously this place is a little bit difficult because not only you have A and V, but you have CS potentials also, and you have pathway potentials also. So very important
sir.
to tease out these things.
Yes, sir.
I think one more
Yeah.
point I want to make for the fellows. So most important is that you should not target just A here basically, because what happens, there is a slant and the pathway starts from the diverticulum, and this is not a pathway basically. These are all CS muscular fibers, as Dr. Vivek has said, and they are connected in a broad band to the LA. So if you ablate in the LA, you cannot ablate this pathway, atrial end. So you have to go to the neck of the diverticulum and ablate, because that is the area the pathway dimension is shortest. So that there the thickest fibers are there, and it is crowded in one place. That's why we target the neck of the diverticulum.
Yeah, nicely presented, Indrajit. I think Vivek and
Thank you, sir.
Sujit have told most of the points. I wanted to highlight again that same thing, that the ECG, you can nicely see the steep negative delta in lead 2. That should alert you. I think any patient with a left posterior pathway, redo, you should be aware that it might be a diverticulum. Anytime there's a recurrence, think of diverticulum. And like Vivek said, this kind of dissociation between antegrade and retrograde conduction also, even though you can see with all pathways, tends to be more common with, I think, diverticulum connections. We've seen that also. Often you can get antegrade gone, but retrograde still present. Important to check both and not just assume that just because pre-excitation is gone, that the pathway is gone. And again, like Suchit said, these you have to be approached like atriofascicular pathway. You're not ablating the atrial insertion or the ventricular insertion. You really have to ablate the middle of the pathway. And so looking for that CS muscle potential is key. And that is found along the neck. So you map along the neck and this. Only other things we do slightly differently probably is I'd prefer to do a direct CS venous angiogram instead of looking at levo phase, because you get better delineation. And also do it in an LAO view, so that when you're mapping in the LAO view, you know better where you are exactly in terms of the diverticulum and the neck. But otherwise, I think good case.
Dr. Raja, they were the best of the remarks. So ladies and gentlemen, I think you agree with me. We have had in this first session 6 great presentations and moderated by the best of the teachers. Raja, thank you so very much. It is because of you this particular summit, gets some importance, and all your residents who participate so enthusiastically, and then they make all of us learn. Raja, thank you so very much. And if time permits, do join back when we take a break.
Yeah.
And Dr. Ching and Vivek, Suchit, Yash, I'm sure he's going to be coming back after the break. Ladies and gentlemen, wonderful learning for me at least. And I think most of the electrophysiologists who are practicing also who are there online, they have learned. And this is a platform that's going to inspire the young electrophysiologists. So let's take a break. And then we come for the second session, which is going to be at 7 o'clock. So till such time, take a break, have a cup of tea. All right.
Thank you. Good evening.
Share your screen and get started with the thing. And thank you so much, sir, for the opportunity. You always have been very welcoming to us. Thank you so much once again.
You are the general of the army forces of the EP.
Thank you, sir. Thank you so much.
Saran, you can welcome him and then start.
Dr. Tan, we welcome you, sir. Kindly start your presentation.
Am I audible, sir?
Yes, absolutely.
Okay. Can you see my screen, sir?
Yes.
Okay. So I start like this. I am Dr. Tan's EP fellow from Kolkata, and also my mentor, Dr. Deepabrata Peros. And firstly, good evening, everyone. And firstly, I thank Dr. M. Bandrajisa and his team for giving opportunity to present the case. So my topic is outflow tract PVC, one to ablate and one not to ablate. So I'm going to my case. This is the case one. A 51-year-old lady. She is suffering the shortness of blood and symptomatic palpitation, and no history of syncope attack and no other comorbid disease. And ECG showed the outflow tract biochemical PVC, and echo showed normal LVEF and no other structural abnormality. This is the heart baseline ECG, and this is you can see there is the biochemical PVC. And this is morphology is monomorphic and constant coupling interval. And you can see in the 2-3 AVRs it positive, and AVR is negative. So most likely this is the outflow tract PVC. And you can see in the V1 is there is RS complex. Mostly this is small r, and you can see the transition in V4. There's a PVC transition in V4. So look at the sinus rhythm. In sinus rhythm transition in V4. So according to this, that's more likely is RVOT PVC. And this is the ECG in the caplet. And this is also the same with the previous ECG. And so there you can see there's the 2-3 AVS positive, and there's RS complex in V1 and transition in V4. So I would like to but in the mode in the RVOT because there's no earlier transition in V1 and V2. So firstly, with 3D Caputo system and reconstruction of the right ventricle and RVOT was performed, and activation mapping was done, and earlier PVC was met in the RVOT. So in this picture, you can see there's we got 24 milliseconds earlier activation than the surface ECG. During the mapping procedure, because PVC is very less frequent, so we get the isoprenaline infusions, and after giving the isoprenaline, then we got some clinical PVC. So this is the clinical PVC, and this is the base mapping PVC, and there is 97% matching in the RVODs, just below the pulmonary vein. So we do the coronary, before the ablation, we do the coronary angiogram, and coronary angiogram show this normal coronary artery without stenosis, and that all the ablation catheter is all very far away from these left main coronary arteries and the left anterior descending coronary artery. And this is the coronary angio videos. And this figure is the 3D mapping image of the RV and RVOD. And you can see in this figures that there is this yellow line is the initiation of the QRS complex, and we got 24 millisecond earlier than that signal in the QRS complex in surface ECG. So we do radio frequency ablation in this size. This is we show in the red color, and with 30 watt and 45 degrees Celsius with aggregations. After the radio frequency ablation, there's no more PVC, and we cannot induce the PVC even after giving the isoprenaline over the 30 minutes. So I'm going to my case 2. This is the 21-year-old young lady presenting with the symptomatic palpitation and no history of syncope, death, and no comorbid disease. And the ECG showed the outflow tract PVC, and echo show normal RBES and no other structural abnormality. In 24-hour photon monitoring show the percentage of 6% in PVC burden. And this is how surface baseline ECG. You can see in the V1 is there's very prominent R in V1. And you see that the PVC morphology is the transition in V3. And we look at the sinus rhythm, there's transition in sinus rhythm transition is V5. So PVC morphology transition is more earlier than the sinus rhythm, and there's more negative negative in you see AVR is more negative than the AVR. So according to this ECG, the most likely is the LVOT. So this is the laterally ECG in EP tablets. That's very slightly different from the previous surface ECG. You see this the 2-3 AVF is positive and small R is complex in V1. That's more similar to the case 1 12 ECG we previously showed. So it could be LVOT or RVOT. But then, particularly in this case, we would like to map LVOT firstly, because there's dual transition is B3 early transition, and dual transition is more earlier than the sinus. So so we would like to map the LVOT first, and we don't get the good signal, we can go to the RVOTs. So we do the mappings in the RVOT using the 7 French irrigation ablation test catheter and via the right femoral artery, and 3D cardiac system reconstruction of the AV and LVOT was performed. At this case, the same problem is the PVC becomes very infrequent. So we get isoprenaline, but in this case, we don't get the PVC. So we depend on the pace mapping. During the pace mapping, there is the 97% matching with the clinical PVC at the superior part of the left coronary sinus. In this figure, you will see this is the pace mapping in the LCC, and this is the clinical PVC is 97% matching. And this figure show this is the LAO view, and this is the RA view of the mapping that is. At the time, we see there's some movement of the suspicion of this movement of the catheter. So that's very close near to the left main coronary artery, and we do the coronary angiography. So coronary angiography show the normal left coronary artery without coronary stenosis, but you see the thick of the ablation catheter is into the left main coronary artery in fluoroscopy. This is the AP view of the fluoroscopy, and you can see in the view of the angiogram. And this is the LAO view, and you can see in the LAO angiography, this is the tip of the mapping catheters over the left main coronary artery. And this is the RAO view, and you also see this RAO video of the coronary artery, coronary angiogram. So at this place, we got good pace mapping is what inside the left main coronary artery. So there's no possibility of ablation to this area. So we find the other safe vantage point for the same size of ablation. Firstly, we move the mapping catheter over the little upper part of the LCC, and but this side we don't get the good signal because base mapping is short the 55% matching. You can see in this this is the clinical PVC, and we got base mapping PVC at this size. And then we move tip of the ablation below, just below the LCC, and in this is also we don't get the good base mapping. This is shown in the matching is 66%. And this is the clinical PVC and the base mapping PVC at this side. You can see there's a 66% matching and not good. So we also trying the CS catheter to reach this area, target area of ablation, but we don't get signal, and in this area also we don't get good matching, and base mapping is not good in this area. We also try this RV catheter into the RVOD outflow tract with the RVOD above the pulmonary vest, and we do not reach the target site, and we don't get the good signal and bad base mapping. So my final diagnosis is LV summit PVC inside the left main coronary artery with an accessible size. So we decide to stop the procedure due to the high risk of the complication like coronary stenosis, occlusion, and spasm. So we decide to give the optimal mericaptamine to patients and follow it. This is my take-home message. This is LVOD and RVOD PVC can have similar morphology. LVPV pattern with inferior axis, like my case 1 and case 2 previously I showed. And LV sandwich can be inaccessible as time. Other vantage points can be way out in selected cases. Risk stratification is more important before ablation. Coronary angiography is mandatory in LCC aortic ablation area. And during the ablation, since we are part of the RVOD, angiography is also available as left main coronary artery close to the posterior RVOD, and LAD is close to the anterior RVOD. So catheter elevation is not recommended within the 5 mm coronary artery or within the 10 mm of the coronary ostia. Thank you, sir.
Dr. Tan, thank you so very much. Great 2 cases. When to ablate, when not to ablate, what are the vantage points, etc. Wonderful. This is the day-to-day clinical scenario. Over to the moderators.
Yeah, I think a wonderful presentation and good 2 illustrative cases of outflow tract PVCs. Well, a couple of basic clinical questions to the presenter.
Yes.
The first case of RVOT
Yes.
PVCs. Now this, my question is this, that do we routinely need a 3D mapping system for a standard RVOT PVCs? Can they be ablated successfully with a 2D system? Because that's been the experience over the years. 3D has its advantages, but do we really need it? That is number 1. And the question 2 is that do we really need a routine coronary angiogram for outflow tract PVCs when they are ablated below the cusp? If you have to go above the cusp in the RVOT pulmonary valve area, yes, a coronary angiogram is essential, is must. But below the cusp, I'm not too sure whether it should be a standard practice to do a coronary angiogram. So these were my 2 questions, and yeah, I would love to hear from you.
So, okay, sir. So in you asked a 2 question, and first question is the PVC ablation within 2D or 2D with or with 3D, yes?
Correct.
So actually in my country is not available 3D. So some of the case some of the PVC ablation is done by the 2D techniques. So I see 3D technique in here. That's first I see in here. So it is more in 3D. We can know the exact point of the ablation, and we can know the exact size of this substrate PVC, and we can know the after we do the ablation, we know the or what area is ablated or not ablated. We can know from the 3D sets.
Correct. I think so. The greatest advantage of 3D system would be that once you have ablated in a particular spot, you can tag it and you can give buzzes surrounding it. I guess in an infrequent PVC, not sustained PVC, that becomes the advantage. So I see that that's the only point. But yes, I would let probably all the postgraduates or those who are doing EP fellowship, let them understand that there are many arrhythmias that can be easily tackled with equal efficacy with a 2D system. And it's always judicious or wise to understand that when upfront you should use a 3D system and when you can use it as a standby or a second approach.
Yes.
The final question before the other moderators can take over is that the second case which you showed, that was of a PVC coming from the left main coronary artery. Now, you wisely labeled the topic as when to ablate and when not to ablate. And you said that the second case was a situation where you would not ablate because the collateral damage is unacceptable. Absolutely right from that front. But my question is that was there even a need to do a EP study in the first place? Your burden of PVCs were infrequent. Your PVCs came very infrequently during your EP study. Your LV function is normal, if I get correctly from the clinical story. So you need to understand that from the PVC morphology, if you suspect that it is likely to be from the LV summit region and the clinical problem is not very significant at hand, why do the EP study? You can follow up this patient and consider whatever medical treatment, or only if it becomes a burden enough in terms of either PVCs or the LV function or symptoms, one can then consider doing the EP study. Otherwise, EP study itself, to my judgment, was not necessary.
Yes, sir. I got it.
Sir, if I can answer or comment.
Sure,
Very pertinent questions as you. Yeah. So first of all, 2D versus 3D, as you said, is very, very and often doable on 2D. Especially, I have been growing up seeing you, yes, sir, Narasimhan sir, doing under 2D. I would say there is, in additional to, I definitely find that 3D helps in certain ways, that it gives you little more accuracy. You can bracket it from the other sides along with the simple color coding. It helps especially for average operators like me. Secondly, when you are, sometimes your first of the ablations is not successful. So let's say you give the first energy and you tag that is unsuccessful. So you know where you have ablated and you have to go to the other places. So this is another advantage I find on 3D. Your second question was about angiography, routine angiography. Obviously, where we are ablating in the left coronary cusp, it becomes mandatory, especially in the upper part of the left coronary cusp. I would still advise for anyone who is doing in the lower part of the left coronary cusp or left sinus of Valsalva, the bottom side. You may not do it if you are below the valve, maybe the superior or lateral mitral annulus. The second part of the question again is about coronary angiography in RV outflow tract PVC. Often if it is in the posterior RVOT, I have one or two cases where it was very close to the left pen coronary artery and I had to leave it alone. Similarly, a couple of cases I have seen and being presented that the anterior RVOT, it was very close to the left anterior descending. So I would advocate doing it will be more safer. Obviously, your and other moderators' experience is much vast than me. I will be eager to hear from the thing for the same. The third is about the last patient where we did a IP study. The patient was reasonably symptomatic with palpitations and actually dizziness during those episodes of bigeminy. However, given the fact that when we mapped it, I thought it could be a left coronary cusp, but it turned out to be inside the LMCA. We obviously had to stop and try other medications. Thank you.
Abhishek?
Yes, no, great discussion, great points. So, just mostly for trainees, you don't really need to do even an angiogram to prove that you're in the left main. Because when you go into the left main, your antennas should go up straight away. And, you have done angiography all these years, so you know how the catheter looks in RAO, LAO view in the left main.
Correct.
Same way the ablation is going to look like. But if you want to have some clues, what are the clues that the catheter is in the left main, like the electrical clues? Number one is going to be you will have an A signal and a V signal. So the V signal is coming from the surrounding myocardium, but the A signal there, and you will have a near field A signal. I didn't see the signal when you're doing pace mapping, but if you can look back on your case.
Sir, can you please post the presentation again?
You will
It
have
is
a
not
near.
there, sir. The signals are
It's
not there, sir.
The
I'll
signal is
repost
not
it,
there.
sir.
Yeah.
Yeah.
So you will have, the most important thing is you will have a near field atrial signal, a sharp atrial signal, and that is because the left atrial appendage hangs over the left main. And maybe if I can share my screen a bit, I'll show you a couple of examples of that. So if you get a near field A signal when you're in the LVOT, you have to near field A, not far field A, near field A
Abhishek, you know
signal.
what? Why don't you share your screen, please?
Yes. Let me just finish.
The screen, please.
Yeah. So if you have a near field A signal, you are catching left atrial appendage, and that means you're very, very close to the left artery. And if you're getting a near field signal, you're in the left main. That's number one. Number two,
Than, can you unshare? Sorry, Than, can you unshare your screen, sir? Than, please. Yeah, unshare. Yeah. Now, Abhishek, sir, please go ahead.
Yeah. Number two, when you're coming up from the femoral artery into the aorta and all those things, your impedance is very different. It's about 110, 120 as you're going up the aorta. But as soon as you enter a big structure like an aorta into a small structure like left main, your impedance is suddenly
Abhishek,
going to
you
go.
have not shared your screen.
No, not yet. I'm just going to finish my points and then I'll share the screen. Okay. I don't want to distract you. So if the impedance suddenly goes up from low to high, like it's 100, 110, and suddenly becomes 120, 130, that means from a big structure, you're entering a small structure. So same concept when you are in deep into a branch of coronary sinus, you're deep inside the pulmonary vein, suddenly the impedance goes up. So same concept. Third would be you will have some dampening of blood pressure, because again you're occluding the left main, so you'll have some dampening of the blood pressure if you have continuous tracing going on at that time. Fourth thing, if you pace, you are lucky you captured the part of the ventricle. That would be you're deep inside the left main. But if you're just ostial to the left main or around the left main, you will not capture the ventricle. You only capture the atrium, the left atrial appendage signal. And obviously, if you ablate there, it is people have died on tables, and anecdotally I've heard. Now, once you're in the left main, what you should do? You should not panic and just take the catheter out. Number one, you should release all the curve what is there on the catheter. So the catheter tip should become loose and floppy, because if you yank it out, you can also dissect the left main. That has also happened. So you should just release the curve. If you have irrigation, what you have, you can even irrigate a little bit more so that the catheter tip is not wedged anywhere, and then slowly take it out and release the bend, and then do the rest of it. So one clue, if you're mapping the LVOT, couple of things to do is, instead of starting straight, going straight in, so go straight into the right sinus of Valsalva. If you make a curve, more chances are you're going to end up into the left main. So if you go just straight, then you'll end up in the right sinus of Valsalva, left sinus of Valsalva, and then slightly bend the catheter up, then that will be a marker you're in the left sinus of Valsalva, looking at the signal. And if you want to go below it, I didn't see how you went below it, but I would just pull the catheter back, make it like a pigtail, and then prolapse it down so that you are below the left sinus of Valsalva to map. Now, once I've finished this, maybe I'll just show you an illustration of this. So this, I don't know if you can see my
we can see.
screen.
Yeah, we can see. You can see, sir.
Yeah, so this would be a way by which you are going to go below the left sinus of Valsalva. So you are catching the same, so you are looking at the signal or the LV summit type location below the left sinus of Valsalva. And the reason why you can injure the left main is, again, if you think your left main is somewhere going to be here, your left atrial appendage is on top of this structure. And that's the same reason when you're doing even RVOT mapping above the pulmonic valve, more posterior, more leftward, you can hit the left main, because again, this left atrial appendage is close to it. So the clue there again is going to be an atrial signal. So if you see any atrial signal while mapping in the RVOT, LVOT, much more superior location, that's your clue that you're close to artery, and I would avoid ablating in that, or at least do an angiogram and then see. Then the third thing is all these rules about 5 millimeter, 10 millimeter, how accurate they are, right? So your catheter is at a particular position, and it is also going to move when you're going to ablate. It can go this way, it can go up and down. So again, you have to be very, very careful with these measurements, and start with a low power, see if there is an impact, and then can go up on the power and see what happens. If you now by chance cause ischemia, how it's going to look like, you'll have VF, because you're causing coronary ischemia. You may not ablate the entire artery right away. Initially, you're going to cause ischemia, so you'll see VF. So any unexplained VF, think about coronary angiogram. And then if you cause a infarct, then stent right away, and then see how things go. Okay, I think I'll stop here.
Abhishek and Amit, we had some concern about the so-called the PVC burden in this particular case. What is the PVC burden here? Is it like 24 hours? Is it like long-term duration? That concept, I think, has to be clear. If the PVC burden in 24 hours is significant, I think it is okay. But if the PVC burden within 24 hours is not significant, like definitions, I don't think it carries any meaning if the patient is symptomatic, because some days the PVC burden can be much higher. So the decision, I think, should be based on the symptomatic status rather than the 24 hours burden.
No, absolutely.
Shomo, what do you say about this, Shomo?
Yes, I totally agree. In fact, many of the times these RVOT PVCs and the LVOT PVCs, they will resolve spontaneously also over time. In fact, one study has mentioned that after 1 year, the PVC burden is actually, in most of the cases, is less than 90% of what it was prior. So unless the patient is symptomatic, don't be in a hurry for ablation. If the patient has LV dysfunction, if the patient has a high burden, along with that, then only. If you have LV dysfunction but low burden, then you have to evaluate prior by MRI. Don't be in a hurry to ablate.
Yeah. All right. So MRI is also another issue. But then, Shomo, I think you told if the patient is symptomatic, yes, and patient is saying that do something, I think that is what is more important than the so-called PVC burden of some duration of monitoring. Abhishek, great comments. Absolutely.
Also, one more thing I would like to say, that importance of pace mapping when the PVC burden is less.
Yes.
Now, what is your output is very important. Adjacent areas that you are pacing, all those things matter. So have a different PVC morphology as compared to otherwise with a low output. So you need to be careful as when you pace map.
A quick comment, Abhishek. Do you really like PVC map? Pace map, do you really like it?
No, the thing with pace mapping is, again, you could be at the perfect site, but you can have a terrible pace map if your output is high. As Dr. Shomu said, you can capture neighborhood areas.
Yes.
And you may be at the wrong site and your pace map may be accurate because you're capturing something distal, which might be your actual exit of the PVC. So both those issues are there. So I generally go for activation mapping, and I just go. So if you look at the ECG where it is coming from, I just go straight there to do my best activation mapping before the PVCs taper away with sedation, all those things, and then what we can find. Absolutely. Just for training, one more thing. So atrial signal would be in the left main, left sinus of Valsalva, above the RVOT more posteriorly, and in the AIV GCV junction. All those places you'll get an A signal and a V signal. And if you're on those sites, definitely do a coronary angiogram before you proceed.
Abhishek, thank you so very much. Great inputs. Stay around. as long as that's possible. I know it may be very odd hours there. But Saran, would you please invite Dr. Punita, the cryoablation?
Good evening, sir. I'll share my screen, sir.
Please.
Is my screen visible, sir?
Yes, it is. Yes.
Good evening, everyone. I will be presenting a case on cryoablation in a post-renal transplant recipient. So our patient was a 57-year-old gentleman who was a known case of diabetes mellitus and hypertension. Both were well controlled on medications. In 2006, he underwent renal transplantation for end-stage renal disease, and he was kept on immunosuppressants, that is mycophenolate mofetil and prednisolone. From December 2023, he had recurrent episodes of palpitations, and during a pre-op evaluation for cataract, he had a ECG which had documented atrial fibrillation. So as his CHA2DS2 score was 4, he was started on oral anticoagulation and rate control with beta blockers. However, he had recurrence of palpitations requiring initiation of amiodarone. Even while on amiodarone of 100 mg OD, he continued to have palpitations. So the dose was increased to 100 and 200 mg alternate day. But in February, he had an episode of pre-syncope, and during that time, the ECG were noted to have sinus bradycardia, and so the dose of beta blocker was reduced. He does not have any history of obstructive sleep apnea, and he is euthyroid. ECG is showing atrial fibrillation with left ventricular hypertrophy and left axis deviation. X-ray was normal. There was no cardiomegaly or pulmonary venous hypertension or pulmonary arterial hypertension. Relevant investigations such as echo showed a good ejection fraction. However, dilated left atrium, it was 44 mm, and left atrial volume index was around 46. He had mitral annular calcification with grade 2 mitral regurgitation and grade 2 diastolic dysfunction. 24-hour Holter showed an average heart rate of 65 beats per minute and a 16-beat AF run. However, there was no significant pause, and his creatinine was 1.9 mg per deciliter. Transesophageal echo showed that there was no thrombus in the LA, left atrium, or the left atrial appendage, and the velocity of the left atrial appendage was 85 centimeter per second. So, thus, in view of paroxysmal nature of arrhythmias, and as he had significant symptoms such as palpitations during the tachycardia episode and bradycardia while on being on drugs, and his comorbid conditions were well controlled. So, he was deemed to be a likely candidate who would benefit with aggressive rhythm control strategy. And after shared decision making, and as the patient did not want to continue amiodarone, we plan to go ahead with ablation for atrial fibrillation and plan to go ahead with the cryoablation. And according to the ACC-AHA guidelines, it is a class 1 recommendation for patients with symptomatic AF in whom the antiarrhythmic drugs are ineffective, contraindicated, not tolerated, or not preferred, and who continue to be a candidate for rhythm control strategy. However, there are a few various challenges to be noted in while doing a cryoablation for patient with post-renal transplant. One is that contrast CT could not be done in this patient to delineate the pulmonary veins, as his creatinine was 1.6 and there was risk of worsening of the renal function. So a nephroclearance could not be obtained for the same. And also the immunosuppressive medications would lead to increased risk of infection, delay the wound healing, and have significant drug interaction with other antiarrhythmic drugs and also the oral anticoagulants. Most importantly is the femoral venous axis. So in a renal transplant recipient, the donor kidney, the renal vein of the same would be anastomosed to the recipient's iliac vein. So there would be chances of stenosis or thrombus formation at the site. This is a schematic representation of the renal vein anastomosed to the iliac vein. And during the angiography, here it is noted this is the renal vein, which is anastomosed to the iliac vein. So in case there is a stenosis, then hardwares which require a 14 French or higher size axis would be difficult to pass through the iliac vein. So initially, and also this patient, as we could not do a CT angiography for the pulmonary veins, we had to use eyes guidance for locating the pulmonary veins. So in this case, first we took a femoral venous access under ultrasound guidance and passed a thermo wire into the inferior vena cava under fluoroscopic guidance. And later, as we had to use a 14 French sheath, which would be around 4.6 mm in size, we passed an advanced balloon of 7 mm size and placed it at the junction of the iliac vein and the renal vein and inflated it to 3 atmosphere pressure. And the fluoroscopy performed showed a widely patent iliac vein and renal vein. So hence we decided to go ahead with the cryoablation, and a basal electrophysiology study was done, which confirmed atrial fibrillation and HV interval of 52 milliseconds. So after this, under general anesthesia, the esophageal temperature monitoring electrode and also the CMAP electrodes were placed for diaphragmatic monitoring. So a transeptal puncture was performed under fluoroscopic guidance as well as with eyes guidance with the standard techniques using a BRK1 needle. Here we can see that the left atrium is dilated, so the interatrial septum is bulging towards the right atrium. And a transeptal puncture was performed under standard techniques. After this, FlexCath Advanced 14 French sheath was passed and an Archives Advanced Mapping Catheter was used to map the pulmonary venous potential, and an Arctic Front Advanced Pro 28 balloon was used for cryoablation. So the lower left pulmonary veins did not show any pulmonary venous potential in the Archives Mapping Catheter. However, the left superior pulmonary vein showed pulmonary venous potentials, and hence both the left-sided pulmonary veins were ablated. So here we can see the left superior and left inferior pulmonary vein with the Arches mapping catheter and the Arctic Front Pro Advance Pro 28 balloon, and cryoablation of both is being done, and a temperature esophageal monitoring electrode was placed to monitor the temperature. And here in this case, the freeze was stopped at 216 milliseconds as the temperature of the esophageal electrode fell down to 27 degrees Celsius. So during the freeze of the left superior pulmonary vein, there was some delayed pulmonary venous potentials which are noted, and later there was complete disappearance of the same. So some of the freeze artifacts that were noted during the cryoablation. So similarly, we mapped the right superior and the right inferior pulmonary veins as well. The right inferior pulmonary vein did not show any potentials, but as the pulmonary venous and the atrial junction are sites for reentrant tachycardias and risk for AF, we ablated both the right upper and the right inferior pulmonary veins. So here we can see that the contrast is being injected to confirm that there is no leak back into the left atrium, and then the cryoablation is being performed. The His catheter is placed in the superior vena cava, and it is paced at 60 per minute so as to note that there will be maintenance of the diaphragmatic neurological integrity during ablation of the right-sided pulmonary veins. So the diaphragmatic integrity was confirmed with under fluoroscopic guidance using the CMAP electrodes as well as palpation of the abdomen. So here the His catheter, which is placed in the superior vena cava, is being paced, and the diaphragm which is transmitted to the diaphragm. So the phrenic nerve integrity is maintained, and also the potentials were noted in the CMAP electrodes. During the ablation of the right superior pulmonary vein, the tachycardia got induced, and later it got organized into atrial tachycardia with 2:1 AV block. And the earliest activation was at the CS 9 and 10. So with a tachycardia cycle length of 280 milliseconds, a possibility of atrial flutter was also considered. So we entrained the tachycardia from CS 9 and 10, and however, the difference between the post-pacing interval and tachycardia cycle interval was 90 milliseconds. So the flutter was ruled out. During the entrainment, the tachycardia got accelerated and later it terminated spontaneously. And repeated attempts on entraining the tachycardia did not induce the tachycardia, and hence the procedure was abandoned. There was entrance and exit block which was noted at the pulmonary veins. The final ECG is showing a sinus rhythm with a narrow QRS interval. The sinus cycle length was 778 milliseconds. HV interval was 36 milliseconds. This is the 3D mapping showing isolation of all the pulmonary veins. So thus, atrial fibrillation affects nearly 30 million people globally, and general population, the incidence is around 1 to 2%. And post-renal transplant, the prevalence of AF is around 7%, and the incidence is around 5%. So the coexistence of all the comorbidities such as hypertension, diabetes, being on immunosuppression adds risk, as the immunosuppression can interact with other drugs such as the anti-arrhythmic drugs and also the NOACs. Amiodarone and tacrolimus interactions can lead to prolongation of the QT interval. And also the immunosuppressants might lead to or accelerate the cardiovascular diseases. And if there is AF, then there is increased risk of stroke as well. So it is noted that post-renal transplant patients who have AF, there is increased risk of mortality by 85% and graft loss by 63%. So this single center pilot study, which was conducted by Zinn et al. To note the safety and efficacy of catheter ablation in for AF in those who underwent solid organ transplant. He had followed up 9 patients from 2015 to 2019 who underwent renal transplant for a mean follow-up of 30 months. And it was noted that there was no difference in the period of AF free period of AF recurrence between the two groups, and also the number of patients who were in sinus rhythm after repeated ablation was also similar between the two groups. There was not much vascular complications noted, and there was no life-threatening complications noted between the two groups, and there was no transient allograft dysfunction in the renal transplant and the hepatic transplant recipients. So thus, cryoablation can be a promising option for atrial fibrillation in post-renal transplant patients. And also there is a complex interplay between immunosuppression, the comorbidities, and the drug interactions with the traditional antiarrhythmic drugs. So it may be suboptimal in these cases. So thus, cryoablation can be considered as an option for successful rhythm control strategy in such patients. Thank you.
Dr. Punita, great presentation and a reflection of a great mentorship you are undergoing under a great mentor, Nambudari, in a great institute like Sri Chitra. Absolutely great. Over to the moderators.
Sir, can I ask a couple of questions?
Yes, sir.
Yeah. So I just wanted to understand, because intuitively I was thinking that, let's say you are planning for a fifth ablation in a patient who has a post-renal transplant. Had you been doing a radio frequency ablation, you could have avoided the small amount of contrast which you have used. Just
Sir,
a question. So
yes, sir. So one thing with radio frequency ablation is the amount of contrast is less, but the risk of like thrombosis or the pulmonary vein stenosis will be more with radio frequency ablation than with cryoablation. So that is why we went ahead with the cryoablation.
So that is
I am not
in general you are talking.
Punita.
Yeah.
Sorry to interrupt, but Punita, there have been sufficient studies saying that generally RF ablation and cryoablation in terms of success for PV isolation is the complications are not very different. Success rates are more or less similar. In the transplant group, is there a particular advantage of one technology versus the other from the literature or from limited experience you have? Is this group more safer with a cryo versus RF ablation is what we would like to know.
Sir, in literature of cryoablation patients, 70% success rate was mentioned. With radio frequency, it was around 50 to 60%, sir. That is what I could find. So maybe better chances of successful ablation with cryo than radio frequency ablation.
Any particular reason? Because it doesn't sound, I mean, I fail to understand what could be the reason why in transplant patient success would be higher with cryo versus RF.
Sir, they had given that the risk of thrombosis and also the pulmonary vein stenosis was more with cryo. I mean, more with
We could have
radio.
Abhishek's. Abhishek, can you comment on this? I mean, we
Yeah.
have little experience on this.
So I mean, the debate continues, which is a better energy source, RF, cryo, or not PFA for us when we are using it. If you think about conceptually, I don't think it should matter, right? I mean, we are still doing pulmonary vein isolation, and the end result is pulmonary vein isolation. So regardless, you have liver transplant or brain transplant, the outcome should still be the same with the if you're treating AFib. So I'm not sure about that. And the main randomized control trial, Fire and Ice, showed the outcomes were the same with RF and cryo. And now, unless you're ablating inside the pulmonary vein, there is really no reason to have pulmonary vein stenosis. So, so that kind of becomes a moot point. But nice presentation, Dr. Punita. I had one question. You showed all the ablations, you were doing it in atrial fibrillation. Any particular reason for that, or it's just the practice, or like, for example, a lot of us here would ablate in sinus rhythm or with a paced rhythm, so you can see those PV potentials disappear. But in AFib, it's just hard to see those pulmonary vein potentials disappear because there's so much far field atrial signals also. So just wanted to get your thoughts on that.
Sir, at the start of the study only, our patient was in atrial fibrillation, sir. He was not in sinus rhythm. So we had to ablate him during the atrial fibrillation episode. When we took him
Okay.
up for the EPS study, the basal study itself showed AF.
Okay. And now based on the map, what you showed, it looked like a lot of the posterior wall got isolated. So do you think that at least for the inferior isolation, was it too antral? If you go back on the map, what you showed, like second last slide, I think.
Yes, sir.
Abhishek, before the slide comes up, you know what? There is this practice, in India in general, we don't do many of these AF ablations, but there's a good feeling, if you are ablating during the AF, and then as those potentials disappear and then the sinus rhythm is restored, it is a good feeling. But I do agree with you that in those cases where it is essential that we are looking at those potentials, whether it is paroxysmal or persistent, long persistent. If you're doing a good job of a PV isolation, I think doing it under sinus rhythm is the best approach. I agree. But I think
It's the same concept when you're mapping and ablating accessory pathway, right?
Exactly.
You see it better when it goes away if you're pacing rather than in tachycardia, the catheter is more stable and everything else. But more importantly, from AFib, sometimes if you're doing it in sinus rhythm or a paced rhythm, and now you have initiation of AFib during the procedure, at least you can figure out where the trigger is coming from rather than just being in AFib. But that's just a practice, everybody does it different, which is fine. But now look at your right map. The right map, I think, is a posterior view, right?
Yes,
You
sir.
see a
Posterior
lot.
view.
You see a lot. There's a lot of grayness there, right? For people who don't see these maps often, what is that grayness? Is that where there is no electricity, correct?
Yes, sir. No electrical conduction. It is isolated.
But you now, if you can tilt the map down, you see a part of your posterior wall is gray and part of it has some colors,
This part, sir.
and on the roof too.
Yes, sir.
Right, so this would just tell you that maybe the left-sided veins were isolated more antrally, that you got rid of most of the posterior wall, and compared to the right-sided veins. So why this becomes important, that this, I mean, I hope not for this patient, but these could lead to some flutters now, because you may leave a gap on the posterior wall somewhere, and if any of the veins reconnect, then there is a risk of flutter. So that's why the aim is still to do more towards the ostium isolation, so you can reduce the risk of atypical flutters.
Okay, sir.
Yeah, great comments, Abhishek. A lot of learning from you. Punita, congratulations. This is really AF Abhishek and even Amit will agree with me. AF ablation in general, because of our own way of practices, the cost constraints, no insurance, unacceptable recurrences in high risk cases. We are not adopting it, but inputs like yours help us to take up some cases where the needy ones are given this therapy, including cryoablation. Punita, thank you. And we'll invite Shubham Sharma. Saran, you can put up his presentation. Abhishek, what is the time now there?
It is 9:20 in the morning. I'm just here to round after this conference is over. So
thank you so much making time for us.
Good evening, sir. Am I audible?
Yes, you are audible and your slides are seen very well.
Yes, thank you, sir. This is Dr. Shubham here from UN Mehta Institute of Cardiology and Research Center, Ahmedabad. I will be presenting a case of SVT with aberrancy versus VT in a diseased heart. So a 58-year-old gentleman with complaint of pain, with complaint of palpitations and dyspnea since last 2 hours presented to another hospital. He had a history of PTCA done way back. So the presentation ECG had a wide complex RPD morphology tachycardia with VA dissociation. On presentation, patient was hemodynamically unstable and hence he was DC-verted. Post-DC version ECG had the sinus rhythm with the same QRS morphology as that of the tachycardia, that is RBBB with the inferior axis. So this brings us to the dilemma that tachycardia ECG and sinus ECG having same morphology and same axis can be an SVT with aberrancy, but it can also be an VT. So the differentials include his Purkinje reentrant VT, which can be a bundle branch reentry VT, an interfascicular VT, or a focal his Purkinje VT. It can also be a scar VT with exit side near the conduction system. At the same time, SVT with aberrancy cannot be ruled out, as it can happen in case of an AVNRT or a junctional tachycardia with aberrancy with VA block, or in case of a retrograde nodofascicular or notoventricular pathway. The patient had an echo done outside where the LVF was 15%, severe LV dysfunction with RWMA, and there was a posterior basal LV aneurysm. Coronary angio done suggested triple vessel disease. He was taken for CABG with plication of the aneurysm with the intent to isolate the scarred area so as to prevent future recurrences of ventricular tachycardia. Unfortunately, on the 5th post-operative day, patient had similar wide complex tachycardia. He was hemodynamically unstable, DC-verted, started on IV amiodarone and discharged on oral amiodarone. Later on, patient had 4 episodes of same wide complex tachycardia over next 1 month, despite being on antiarrhythmic drugs. This time, all episodes were hemodynamically stable. Thereafter, the patient was referred to our center for an EP study and RF ablation. During EP study, the baseline rhythm had wide QRS morphology with 146 millisecond, RBBB morphology with QR in inferior leads, suggesting a left posterior fascicular block. The intracardiac EGMs had an HV interval of 63 milliseconds. With the help of 3D mapping, we first created a scar map to delineate the scar and the periscar areas, and then proceeded with the usual EP protocols. On atrial pacing, we had a HV block indicating an infrahesian disease. On ventricular extra-stimulus testing, an RBBB tachycardia similar to the event tachycardia was initiated. On looking at the intracardiac EGMs, we saw that it was actually an A on V tachycardia with a VA interval of 46 milliseconds. So initially we thought that it can be an AVNRT. However, On closely looking at the HV interval, we can see that the HV during tachycardia was 43 milliseconds. Not to forget, the HV during sinus rhythm was 63 milliseconds. So an HV during tachycardia being less than the HV in sinus rhythm rules out supraventricular tachycardia. At the same time, if we look at the HA interval, then the HA interval during ventricular pacing was the same as that of during tachycardia, that is 86 milliseconds. This also rules out an AVNRT. So we came up to the diagnosis of a ventricular tachycardia. Atrial pacing was done, which entrained the tachycardia with concealed fusion. Then looking at the intracardiac EGMs with the decapolar catheter placed along the left bundle, we can see that atrial pacing lead to AHHA response on entrainment, again reinforcing the diagnosis of a ventricular tachycardia. Closely looking at the signals in the His and the decapolar catheter, we can see that during atrial pacing, the His potential precedes the activation of the left bundle. However, during the tachycardia, we can see that it is the left bundle which gets activated prior to the activation of His bundle. So there was a reversal of His and left bundle activation. This all points towards an interfascicular VT. Concluding again, an underlying LV dysfunction, wide complex tachycardia with VA dissociation, right bundle branch and right axis deviation, HV during tachycardia less than HV during sinus, and reversal of His and left bundle activation. All this proves it to be an interfascicular VT. An interfascicular VT can have a right bundle branch block with a right or left axis deviation depending upon which limb is acting as retrograde or antegrade. A tachycardia with the RBBB and right axis deviation has an antegrade anterior fascicle and retrograde conduction via the left posterior fascicle, as in this case. However, there can be a tachycardia with RBBB left axis deviation where the antegrade conduction is through the left posterior fascicle and the retrograde conduction is through the left anterior fascicle. Different variants of bundle branch reentry tachycardia have been described. So the type A variant mentioned here, in this the antegrade conduction takes place to the right bundle, then the transeptal activation followed by the left bundle activation. This type of tachycardia will give a left bundle branch morphology on the surface ECG. Then the type C variant, which is just opposite to the type A variant. In this, the antegrade conduction will be over the left bundle, followed by transeptal activation, followed by right bundle activation. This will give a right bundle branch morphology on the surface ECG. The third variant, that is the type B variant, this is actually an interfascicular VT in which we have a right bundle branch block with a right or left axis deviation on the surface ECG. Taking and noticing the HV interval is very important to differentiate and come up to a diagnosis of an interfascicular VT. The HV interval during a bundle branch reentry VT is either the same or more than the sinus HV. However, if the HV during tachycardia is less than that of the sinus HV, it is an interfascicular VT. So after coming up to a diagnosis of an interfascicular VT, we then proceeded with ablation. Initially, we ablated at the posterior fascicle. However, the signals there were not very great. It did not yield any result as the area was very scarred. So we then proceeded with ablating near the anterior fascicular region, knowing very well that it can lead to a complete heart block. As you can see, the larger arrow on the top of the screen points towards sharp fascicular potential, which precedes the ventricular EGM, while the VA Venke back is going on and RF ablation is being done. We continue to do RF ablation in the same region, which yield to a retrograde VA block and a VA dissociation. However, the thing to notice is that even though there was VA dissociation during RFA, but the tachycardia continued. So anterior fascicle has been ablated, posterior fascicle ablations have been given, it was already diseased. So now we have created a VA dissociation, but the tachycardia still continues, which is something against an interfascicular VT. So now we thought that the possible mechanism or explanation for this is that the re-entry circuit is taking place distal to the site of ablation. So ablation was now given at distal part of the anterior fascicle. An interesting observation noticed here is that in the initial part of the trace, we have an RBB morphology clinical tachycardia, which during ablation transforms into an LBBB morphology tachycardia with a different cycle length. On looking closely at the ablation proximal signal, we can see that there is a sharp fascicular potential preceding the ventricular EGM, which during later part of the trace, that is during LBBB morphology tachycardia, becomes later, indicating that the left bundle branch morphology tachycardia is actually a myocardial VT. We then proceeded with ablation of the left bundle branch morphology tachycardia. The tachycardia was rendered uninducible, not inducible, but the patient landed up in a CHB. These are the sites where the ablation was done. Initially, we tried ablating at the posterior fascicular area, but we failed. Then we had to ablate at the anterior proximal and the distal fascicular areas. Thereafter, the LBB tachycardia was ablated in this region. The patient was given a CRT as he had severe LV dysfunction with requirement for pacing. 3 months follow-up, patient is doing fine with no recurrence of the VT. The take-home message is that if you have a tachycardia with similar morphology and axis as that during sinus, it is not always an SVT with aberrancy. It can very well be a VT, especially the conduction system VT. Thank you all.
Thank you so much. And I think this is going to open up a lot of discussion. Over to the moderators. Abhishek.
Wonderful presentation, Shubham. Sorry, go ahead, Abhishek. You go first.
No, you go ahead. You go ahead. I'm just curious to hear your thoughts. Beautiful case, so.
Yeah, it's a fantastic case. So, in fact, I'm going to ask Shubham, can you go back to first slide? Because, ECG continues to be a passion. Though we are electrophysiology, ECG continues to be a passion. And the very first ECG, I just wanted to highlight this, that you had a wide QRS tachycardia and you had a sinus rhythm ECG. The morphology was very similar looking, but you need to realize the VA dissociation also was pointed out, but simultaneously during the tachycardia, to me, what appeared is that the QRS was slightly narrower, especially in lead V1, as opposed to during sinus rhythm. And this is just for the, for the all EP fellows, that when you have a wide QRS tachycardia, but it is narrower in tachycardia than during sinus rhythm. So in sinus rhythm, you have a right bundle branch block, and now you have a tachycardia. This tachycardia gives a relatively narrow QRS. Look at the V1 here. It's a relatively narrow QRS. And now come up with the sinus rhythm ECG. The sinus rhythm ECG RBBB is slightly wider. So if you have a narrower QRS during a so-called tachycardia, it is very likely to be a VT. A VT, an SVT will be, equally wide or wider. But if you have a narrow QRS with a RBBB underlying, it's a VT. So that's one point which I wanted to make. And the second comment which I wanted to make is, this is my general impression that when you're dealing with a bundle branch reentrant VT and you are going ahead with the ablation, it's a fantastic demonstration of every step that you have done. Congratulate you on that. But my leaning is, when we do ablation, if you have a bundle branch VT, if it's a LBBB morphology, try and ablate the left bundle. If you have an RBBB morphology, try and ablate the right bundle. If you have an interfascicular reentry VT, if it is a right axis deviation and an anterior fascicle origin, try and ablate the anterior fascicle first. If you have a left axis deviation, which is likely to from the left posterior fascicle, ablate the left. This is a way in which you could potentially avoid a complete AV block. Having said that, all these patients require a device because they are sick hearts, and ICD would be implanted. But those are the two comments I wanted to make. Yeah, Abhishek.
So Dr. Vora, one quick question for you. What is the reason the QRS becomes narrow? Is it fusion or just a different way of activation?
So the origin of the VT from the left ventricle. So you have a right bundle branch block, and the origin of the VT where it engages the bundle branches kind of negates the width of the QRS.
Sounds good. So yeah, because one of either that could be that, or because of so much delay in the bundle branch, the VT may just fuse to kind of peel off little bit of that refractoriness to make it a little bit narrower. That potentially could also be, one of the explanation. But no, fantastic case. So Dr. Shubham, couple of comments and questions. So when you go into a case like this, I mean, you are so well prepared and beautiful, beautiful tracings. Is what was the approach of mapping? Like when you're mapping these kind of tachycardias, were you looking to map the earliest V, or what was the approach for mapping? Because you made a map initially, right, to show the scar, which I assume was in sinus rhythm or pacing, where you showed the whole posterior wall was scarred up. But for particularly doing 3D mapping of this tachycardia, what was your approach?
So, sir, initially we created a scar map, then we did the usual pacing protocols. We did map the tachycardia during during tachycardia. We did the mapping. We did create a propagation map, but unfortunately, due to some financial issues, we did not have very high resolution mapping. We did not have HD grid, so the propagation map was not that good.
Well, I'm glad you
We
did not see the.
did try to entrain the tachycardia from the anterior fascicle. However, on repeated attempt to entrain the tachycardia, it used to transform from RBB to LBBB morphology. So that could not be done.
Well, actually, I'm glad you are not able to do a 3D mapping of that tachycardia, because when you're mapping anything on a mapping system, you're either going to map the A or the V or some signal, right? But if you map the earliest V in this signal, that has actually no meaning, right? Because the re-entry is not happening in the ventricle, it's actually happening in the fascicle. Right, so you can make any of these beautiful looking propagation and all these fancy things what they will show you, but that has no meaning because the re-entry is not happening in the ventricle, it's happening in the fascicle. But where it does add a little bit value, it gives you a ballpark where the exit of the VT is going to be. So once you know fairly where the exit of the VT is going to be, then you forget about that map again. Then you use your point by point mapping to look at all the fascicular signals, what you had nicely shown, and then to identify a target for ablation. The couple of times you mentioned about you're comparing the His V or the fascicle to V signal in sinus rhythm and fascicle to V signal in VT. One observation what you had about how to differentiate VT from SVT was very good, right? The fascicular to V was shorter in VT compared to the sinus rhythm, right? You had one of the slides where which showed that. But then how to know or how to identify the site for ablation? Any thoughts on that? Because you can go on this anterior fascicle up and down, you will see a fascicular signal everywhere, but what would be your proof that this is where I'm going to ablate? Is it going to be pace mapping, yes or no? I can't hear you.
Yes. So pacemaking mapping can definitely be done. So if we have a good fascicular potential, we can do pace mapping. We can try if the 12-lead ECG is showing a good match. Then it definitely means that we are near the isthmus area. We can try to entrain it. And if the PPI minus TCL is less and we are within the critical isthmus, then it should be the site of ablation.
So now if you just think about
Oh.
that, again, we were looking at PPI minus TCL and everything else when you're pacing the ventricle. But again, the re-entry is here happening in the fascicle, right? So unless you purely capture the fascicle without capturing the ventricle and measure the signal from fascicle to fascicle, that's the only way you might be able to show your concealed entrainment, which by the way, on surface will show manifest, because with pacing, you're going to capture neighboring myocardium. So your local, your surface ECG may not show perfect pace map or perfect morphology ever in this area, because the re-entry again is happening in the fascicle, and you will see a lot of fusion on surface ECG, but still you might be in the circuit. So at least the way I think about it, I compare the fascicle to V signal to the fascicle to V signal during sinus rhythm. and then try to see where you become equal and where you become too short. If the fascicle to V becomes too short, that means you're at the exit of that fascicle, because from fascicle you're going straight to the ventricle, so you'll be too short. If the fascicle to V is too long, then you're very proximal to that circuit, because the fascicle has to fire, then go all the way down and then go to the ventricle, assuming you're looking at the same QRS. But then when you're somewhere in the middle, where the fascicle to V is similar to the fascicle to sinus, then you know at least you're a little bit distal to the side, then just inch up a little bit proximally, make sure there is no concern for damage for AV node and all those things, and then ablate there, and that should, get rid of this tachycardia. So, that would be a way of doing it. So actually pace mapping and 3D activation mapping is not going to be helpful for these cases. The actually looking at the fascicular signals is going to be the most important, and then comparing the timing with sinus rhythm.
Also, one more thing, in the sinus rhythm, if you can label the Purkinje system well, the left posterior, maybe the mid-septal and the left anterior, and then during the tachycardia, go back to these points and see what gives the earliest potential and its relationship when the tachycardia is entrained. What comes first will potentially be the site where you want to ablate again. So that is how, unfortunately in this case, the left posterior fascicular potentials were not there, and it was all in the mid septal and the left anterior only where the potentials were seen.
No, absolutely great point. A beautiful, beautiful case. I wish I could do this case.
Dr. Amit, final comments.
No, I think this is a fantastic reportable case, but I completely agree with Abhishek as in terms of ablation approach. When you have a interfascicular reentry, it's going to be a challenge. But yes, you need to go towards as much exit as possible, but not so much in the exit point in the myocardium that you're going to miss the the fascicle altogether. So go distally where your potential to V becomes the shortest, and then come back a little proximal, sufficient enough to kind of get the fascicle, and that's the correct way to ablate this tachycardia. But fantastic case and good maneuvers. Thanks, Shomo.
Dr. Amit, Abhishek, thank you so much. Shubham, you must be really very proud that you are under the mentorship of Shomo, the great. Shomo, hang around. We have another 45 minutes of more. So thank you. Abhishek, will you please hang around?
I'll just comment. Dr. Raghav was there in the case also, and he also deserves that applause.
Oh, wonderful.
Yeah.
Okay, I wish the moderators to stay back. So we go to the final session of the first day of this summit. So we have again another elite moderators here today. I don't know, Nitish, Malini, my friends Deep and Avinash, they must be around. Malini, hi. Dr. Malini. Okay, thank you so very much for taking time out. Deep.
Hello, sir. Good evening.
So let's invite now Sudita Mandal.
Good evening, teachers. Is my slide visible, sir? And am I audible?
Yes, you are audible and your slides are clearly seen. Go ahead.
Good evening, everyone. My respected teachers, the chairpersons, and my dear colleagues. So I'll be presenting 3 ECGs of tail of pacing on the tail. The title I have kept as tail of pacing on the tail of the QRS complex. So I'll directly go into the ECGs proper. So this patient was a case of CHB who underwent dual chamber pacemaker, and on follow-up, this was the ECG. So as you can see, there was a paced and V sense rhythm going on, and there was one probable VPC came here. Probable VPC came here, and after that, there was another pacing spike which caused one QRS to happen, and so there was R on T phenomena, and so to couplets were there. So these are the pacing parameters. So standard pacing parameters were there. Sensitive delay and paced delay were 120 milliseconds and 150 milliseconds respectively. And post-atrial ventricular blanking was 28 milliseconds. So there was VPC followed by one pacing on the T wave of the previous VPC, causing one R-on-T phenomena. So coming to the next ECG, so this was a patient of symptomatic 6-ANA syndrome, underwent dual chamber pacemaker with Boston Scientific. And as you can see, another one wide QRS came, probably VPC. And before that, one pacing spike is also there. And following that, on the T wave of the first QRS complex, there are two pacing spikes, pacing pulses. So one pacing pulse just on the QRS of the first QRS, followed by two pacing spikes on the T wave. So this is also two pacing spikes on the tail of the either paced QRS or the VPCs. So coming to the parameters were standard with post-atrial ventricular blanking period was 65 milliseconds in this case. Coming to the third ECG, as you can see, this was also a case of complete heart block under a dual chamber pacemaker with biotronic device, and we can see that there was ventricular pacing spike, and that has captured the ventricle, caused V-paced wide QRS complex. Following that, another pacing spike came after each and every paced QRS complexes. So this is also pacing on the tail of the paced QRS. So we have, and the parameters were kept standard parameters with normal post-ventricular atrial blanking and paced AV delay and sensitive delay. So we have three problems in these three ECGs. First one was one QRS, wide QRS complex, followed by R-on-T phenomena caused by pacing spike. In second ECG, one pacing spike was on the QRS, followed by two pacing spikes on the T wave. And in the third ECG, paced QRS, followed by another pacing pulse on the QRS, downslope of the QRS. So these three ECGs were having pacing pulses on the tail of the paced QRS or the QRS complexes. So coming to the first ECG explanation. So as it was, the atrial pacing spike was going on. So in this situation, atrial pacing spike came, but simultaneously one VPC came here. So VPC, as we know, after atrial pacing spike, there will be post-atrial ventricular blanking period in the ventricular channel to avoid crosstalk from the atrial channel. So in that period, ventricular channel will be blanked. So that is called post-atrial ventricular blanking period. So after atrial pacing spike, in that period, one VPC came, which was not detected by the ventricular channel. And after the atrial pacing spike, after the AV delay, fixed AV delay, another pacing spike came, which captured the ventricle as it was beyond the refractory period of the ventricle. So the mechanism for this R-on-T phenomena was the VPC was occurring in the post-atrial ventricular blanking period, which was not detected by the ventricular channel. So after the fixed AV delay, which was programmed AV delay, the pacing spike fell on the downslope of the T wave beyond the relative refractory period of the ventricle, and which captured the ventricle, causing R-on-T phenomena. So this was the first explanation for the ECG. Coming to the second ECG, this was Boston Scientific pulse generator. So in this situation also, one VPC came, and at the same time atrial pacing spike came. But as we know that if similarly after the paced AV delay, the VPC came in the post-atrial ventricular blanking period, and which was not sensed by the ventricular channel. And after the paced AV delay, again, the pacing spike came on the upslope of the, in this situation, downslope of the T wave, as it is inverted T wave. So in this situation, the one pacing pulse did not capture the ventricle because that was in the refractory period. So once it is not capturing the ventricle, so as we know, if there is bit-to-bit capture mechanism is active, RV auto capture mechanism is active in Boston Scientific or any other devices. So there will be a backup pulse after loss of capture, confirmed loss of capture. So whenever there is confirmed loss of capture by evaluation of evoked response by the channel, if there is loss of capture, immediately after that, depending on the company, 70 millisecond or 100 millisecond. Immediately after that, there will be a backup pulse with higher voltage output. So usually backup pulse are given with the previous threshold plus 1.5 volts. So usually it will be 3.5 to 5 volts. So higher output will be given, and that will try to capture the ventricle to prevent any asystole. But in this situation, this backup pulse also fell on the refractory period, as you can see on the peak of the T wave, and it did not capture the ventricle. So in this situation, if two loss of captures are there within 4 subsequent bits, so there will be a confirmed loss of capture and device will go into the suspension mode. So in this situation, this is a representative image. As you can see, atrial pacing. So VPC occurred in the post-atrial ventricular blanking, so it was not detected. And after the paced AV delay, ventricular pacing was given, which did not capture. As you can see in the VSense channel, there was no capture of the ventricle. And for that, as there was no evoked response, after 70 milliseconds, there was backup pulse given, and that also did not capture. So this was the second mechanism why there were 2 spikes, pacing spikes on the T wave of the VPC. Coming to the third case, the first image was the third case. So in this situation, so the different differential diagnosis are there. So if there are 2 closely pacing spikes are there in a dual chamber pacemaker, if the interval of the closely spacing spikes are lesser than the programmed AV interval, there are 4 possibilities are possible. So what are the possibilities? So that can be ventricular safety pacing, which will be lesser than the paced AV delay, or in case of atrial lead dislodgement into the ventricle, or ventricular lead displacement into the atrium, or vice versa, or backup pulse in bit-to-bit auto-capture algorithm that I have shown in the previous case. So in these situations, the pacing pulses will have lesser interval compared to the programmed AV interval, as opposed to the first case, which was after the programmed AV interval. So another differential will come when the 2 pacing pulses are separated by exactly same programmed AV interval in normal situation, or in lead reversal on the pacemaker header. When we attach the leads in the pacemaker header, the lead can be interchanged mistakenly. So in that situation also, the pacing pulses can come after the QRS, and that will have the exact same paced or sensed AV interval. And also we have shown that VPCs during post-atrial ventricular blanking period will also have the same paced AV interval. So, and coming to this table number 2, so in each pacemaker, after the crosstalk sensing window, there will be safety pacing. So these intervals will have safety pacing. So in Biotronic, Medtronic, and Abbott, we can see that safety pacing interval will be lesser relatively compared to what we usually program, paced AV interval or sensed AV interval. So 100 millisecond for Biotronic, and for Abbott 120 millisecond, and Medtronic 110 millisecond. In backup pulse, this will be further shorter. So in case of Boston, which I discussed in the previous case, which was 70 millisecond, and in Abbott, it will be 100 milliseconds. So it will be further shorter in case of bit-to-bit auto capture mechanism. So that will give one clue regarding which, if there is some backup pulse is happening, or there is safety pacing is happening in that case. So in this situation, the third case where the pacing pulse came on the downslope of the QRS, as you can see, this case actually the atrial paced pacing captured the ventricle and the QRS came, but the paced QRS was sensed by the ventricular channel, and it was in the crosstalk sensing window, and it gave one backup ventricular safety pacing, and which was lesser than the AV delay, because ventricular safety pacing will be in this case, which was Biotronic, safety pacing was 100 millisecond, and the paced AV delay was kept as 120 milliseconds. So in this situation, the safety pacing came earlier than the AV delay. So this thing started to happen, and this was the representative case and the third ECG. If the reverse happens, so if the ventricular lead comes back into the, because of pull or less loop, it comes back into the atrium. So what will happen? So usually the atrial lead will pace the atrium, the P wave will come, but the P wave will be oversensed by the ventricular lead, which is already in the atrium. So that will be sensed in the crosstalk sensing window, and ventricular lead will deliver one safety pacing, but that safety pacing will not capture the atrium because atrium has been already depolarized. So this will be atrial pacing capturing the atrium, and after the ventricular safety period, crosstalk sensing window, another pulse will be there, that ventricular pulse will be there, and that will not capture the ventricle because it is anatomically in the right atrium. Coming to the B, so as I have already discussed, the VPC, if it is in the post-atrial ventricular blanking period, after it will not be detected in the ventricular channel, and after the paced AV delay, it will have another pacing spike on the T wave. Coming to the third explanation, another differential in this case. So if there is lead reversal on the PG, what will happen? So atrial pace, the atrial lead is connected to the ventricular port. So anything coming from the atrial pacing will capture the ventricle because it is in the ventricular channel. So it will give one QRS after the atrial pacing spike. After that, V pacing occurs after programmed AV interval. So V pacing also will occur after programmed AV interval, but the ventricular port is connected to the atrial lead. So the atrium will capture that V pacing will capture the atrium. So this will not be visible on the QRS, and this will go on. But in few situations where intrinsic, for example, if there is AV conduction is there, in that situation, the ventricular, the QRS will be sensed by the atrial port. So it will start the AV delay. So after this QRS, it will start the AV delay, and it will give the another pacing pulse from the ventricular port. So ventricular port will give the pacing pulse, but that is actually in the atrium. So atrium will be depolarized. So QRS will be sensed by the atrial port, and after the AV delay by the device, the ventricular port will give one pacing pulse, but that is into the atrium through the atrial channel. So that will depolarize the atrium. If there is AV conduction, so this atrial event can fall. So this atrial event will be conducted to the next via the AV node. So if that the AV conduction is slow enough, so that will go beyond the PVAR of the atrial channel. So this will continue as pacemaker tachycardia. So this is not the usual pacemaker mediated tachycardia, where generally V pacing will cause VA conduction, and that A will be again triggering another ventricular event. So VA, the usual pacemaker mediated tachycardia is retrograde conduction via AV node. But in this situation, as the lead reversal happened, so ventricular event will be sensed by the atrial port, and it will give the pacing impulse into the atrium, and that will be conducted through the AV node and cause another QRS. So that will cause almost like orthodromic PMT. The usual PMT is actually antidromic PMT, where the VA conduction happens through the AV node retrogradely. So these are the situation can happen in lead reversal. So this I have already explained, and this also I have explained. So these things can arise. So lead reversal can cause the pacing impulse to come immediately after the AV delay. So in the third case, there was atrial lead dislodgement into the ventricle, and we repositioned the ventricle. So these three problems were there. The first problem was post-atrial ventricular blanking period, and SARCH, because of SARCH AV plus, the AV delay was very long and it captured the ventricle. So that's why R1T phenomenon happened. If there was no SARCH AV plus algorithm, so it could have occurred, the pacing impulse could have occurred on the upslope of the T, and it might not have captured the ventricle. So in this situation, to reduce the chance of R1T causing ventricular tachycardia or ventricular fibrillation, we gave beta blocker to further reduce the risk of R1T phenomenon. and we switched off the search AV plus algorithm. Even if the VPC comes, that will cause pacing after the fixed 120 millisecond AV delay. And in the second case, the problem was similarly post-atrial ventricular blanking period and RV auto capture mechanism. So we started one beta blocker and reduced the ventricular VPC burden, and RV switched off. And in third situation, the lead dislodgement was the problem, and it was actually ventricular safety pacing, and we repositioned it. So take-home points from this is, as the first two patients were absolutely asymptomatic, and all three patients were absolutely asymptomatic. So we can see the symptoms may not be proportional to the pacemaker malfunction. So even if the patient has R1T phenomena and there is considerable risk of R1T causing ventricular fibrillation and sudden cardiac death, the patient might be totally asymptomatic. So that we should keep in mind. Inappropriate pacing on ECG is not equals to pacemaker malfunction. Pacemaker, whatever we are programming, pacemaker is functioning absolutely fine, but that can cause inappropriate pacing on the ECG. That we should keep in mind that first two cases, the device is programmed and the device is functioning absolutely fine. The programming has the problem. But in the third case, the device was malfunctioning because of lead displacement. So inappropriate pacing does not mean always pacemaker malfunction. And knowledge of advanced algorithm is important to identify the problem and solve it. And all manufacturers are not the same, because many manufacturers will have safety window different. The backup pulse timing intervals are different. So few algorithms are not available, like safety window and safety pacing is not available in Boston Scientific. So all this should be kept in mind while evaluating a pacemaker ECG on device clinic. And critical evaluation of ECG can be always life-saving, and it's always fascinating for any electrophysiologist. Thank you.
Dr. Mondal, your stories of pacing, set my heart definitely racing, and I'm sure most of the attendees too. I think you and your mentor, Nambudari, must have lost so many days of sleep. You agree with me? How much time you had put on the analysis of these cases? Just give us an idea. How many days you are thinking about these three cases?
Truly speaking, sir, I have spent at least 1 week to identify, talk to the device.
If it were to be ours, we would have spent 1 month.
Yes,
Nitish,
I talked to all programmers, centers and all, then I identified, sir.
Nitish, I couldn't recognize you. You now are a rock star, Nitish. Welcome. I'm so glad to have you. And let's start the comments from your side. Malini, followed by that, and my friend Deep is around. Nitish.
Yeah, no, I think it's a very good demonstration. I think I really liked your table that you have in the end, where you are really differentiating, where you have inappropriate pacing with normal AV delay and short AV delay. I think that's a very good learning point for people who are analyzing this. And it's very important to, it's very hard to remember different algorithms by different pacing companies. So I think this is a very nice table that you have enumerated. When you get different things, and what should you be looking for when your thing is happening. And most of the times, you're right, it's just an programming thing, but in certain situations, you really have to look for lead displacement. So I think it's a really very nice collection of cases to illustrate the point of how to properly interrogate the pacemaker, because this happens all the time. Your ECGs and telemetry look very weird, and you have to think about the algorithms and go through that. So I really, like the succinct presentation and your summary.
Malini, madam, your comments.
Yeah, I think that was a fantastic presentation. I agree with Dr. Ullas when he said, great collection of ECGs, even those ECGs at the end with that table that you're showing, fantastic. So very little to add to this. I see a lot of interest here, a lot of old friends, and then a lot of fellows, I think, on the call as well. Is that right, Dr. Ullas? Do we have a lot of fellows and trainees?
Most of them are the EP fellows, young cardiologists.
Fellows. Perfect. So for our fellows and trainee audience, I think those, the very last slide that summarizes the take-home points is really important. When you see like two pacing spikes that are too close together, right? So that's one of the take-home points. What are the differential diagnoses? And the way Dr. Mondal said that you have to take into consideration the type of device, the manufacturer, and then manufacturer-specific algorithms, that's really critical. So for example, if you see the same phenomenon where there are two pacing spikes really close to each other in a Medtronic and not a Biotronic device, you have to think about things like safety pacing, but then you start thinking about things like, operation of the MVP algorithm or the non-competitive atrial pacing algorithm. So those are terminology that some of our fellows on the call should look up later online, because I believe Medtronic is frequently used as well in our country. So really, really nice presentation, but making a list of those, just like for this Biotronic device, how Dr. Mondal has made, you can make a list for every other manufacturer. And for Medtronic, some of those algorithms come into play as well. So very nicely done and very nice analysis.
Very well said. Whenever there are two spikes which are closer than that is a program parameters, I think we should be looking at the proprietary algorithms. Deep, we would like to add some more points.
Oh, no, nothing more. He has been so good in analyzing, and for all the fellows who are attending the session, it emphasizes how much important it is not to overlook an ECG, how to try to get into the depths and try to find answer for whatever you see on the ECG, if it is a pacemaker ECG. And then you will find answers. Whatever time it takes, you will get to the answers. Very nice explanation. I enjoyed the presentation.
So Mondal, I know that
Ullas, can I make a point?
Yes, sir, please.
It's a very good demonstration and the table at the end, but I want to make, it's easy to make simple things difficult. It's difficult to make complicated things simple. Now, I have just one comment on the first case. Sick sinus syndrome is a forgiving disease. In a normal heart, you rarely get sudden death. AV conduction delays in sick sinus, if they occur, they don't occur suddenly and are never catastrophic. I'm a little worried that in a benign, relatively non-life-threatening disease, by putting a dual chamber pacemaker, one can come up with these. Your solutions are excellent, but the problem is created by dual chamber. Had you had a AAIR pacemaker, you wouldn't have probably had this problem in the first place. Even at a AV delay of 120 cents, you still have A pace, V cents. So why are and this is my message to juniors, I see that AAIR pacing is almost become obsolete in the younger generation. And I want someone to resurrect it. That is my comment and my anguish.
Dr. Yash, I'm with you, but there is some amount of concern that they may develop over a period of time AV block, and the atrial lead, is more predisposed to some dislodgements. There are some concerns, and then you are right. If you're really very certain that this is typically a sick sinus and it's not going to be ever to have the conduction disease downwards, I think AIR is okay. All right, so Dr. Malini, I wish you stay back for a few more presentation. Nitish, please be around. Dr. Yash, I'm so thankful to you are still around. So we call now Mustafa. He's going to be talking about some Holter ECGs.
Hi, good evening.
Welcome.
I just want to share my presentation.
So you are under the mentorship of?
Yes. Now you saw my presentation now?
Yes.
Okay, nice. So hi everybody. My name is Mustafa Gabarin, AP Fellow at Hamilton General Hospital, McMaster University. Today we will talk about decoding SVT by Holter ECG analysis for a certain patient that we saw him in our clinic. So case history presentation, we start with a 44-year-old male patient referred by his cardiologist to our arrhythmia clinic at Hamilton General Hospital for SVT assessment and management. The main complaint was recurrent palpitations. There was no relative information his history taking. Regards to the medication, started bisoprolol by his cardiologist 2.5 milligram. Physical examination was normal. ECG at rest show sinus rhythm, normal intervals, no evidence of pre-excitation. And already he came with Holter ECG 14 days with a full report. So I will show you the next 3 slides, interesting Holter ECG from this case. So the first Holter ECG, we see here the onset of the tachycardia. We see in the red circles P-wave morphology of the sinus rhythm, we think, and it was around 88 beats per minute. Then we have starting of QRS, it's wide complex QRS tachycardia, and the starting, it's where's the our arrow, the blue arrow. We think it's premature atrial beat with different morphology, P-wave and the interval more shorter, so this is why it's premature. And the tachycardia wide complex was at 165 beats per minute. Second Holter ECG monitor, we show that the wide complex tachycardia still continue, then converted at some point to the narrow complex tachycardia. So we noted that wide complex tachycardia was in 360 cycle length, and the cycle length of the narrow complex tachycardia, specifically the first beats here, was 320 millisecond cycle length. The third Holter ECG here, so we still see narrow complex tachycardia, then there is, in some point, there is termination. So if we're looking for the narrow complex tachycardia, we think at this point here or here, there is a P wave, and we think it's short RP tachycardia, but this RP is still more than 90 milliseconds. And in the end, there is a PVC QRS ended with a QRS, we think, without reach to the A. And this QRS have certain features. This feature of the QRS, it's look like very similar to the tachycardia QRS, but it's a little bit wider. So what's the most like diagnosis here? So it could be an SVT with aberrancy, like orthodromic AVRT. It could be VT converted to SVT is unlikely because it's starting with a premature atrial beats. Could be atrial tachycardia with a transit left bundle morphology aberrancy. And there is long lists here to talk about the differential diagnosis. We think here it's aberrancy case. Aberrancy, it's rate-related bundle branch block, as you know, or phase 3 block. It's a functional block. It could be normalized spontaneously like our case, or force normalized by PVCs or PACs. It's important to differentiate the wide complex tachycardia VT than SVT, and there is certain and multiple tools like Verkis criteria diagnostic tool to differentiate between this wide complex QRS tachycardia. And why I mention what I show you now, the Comel signs or Comel phenomenon, because I think in the second trace Holter ECG, our case was with wide complex tachycardia, it's left bundle aberrancy. So we think it's the left bundle is a part of the tachycardia cycle length, of the tachycardia circuit, sorry. And we will have normalization of the left bundle branch aberrancy. So the tachycardia cycle length was faster, was 320 milliseconds, and here was 360 milliseconds. Of course, common science talk about VA timing, not about the tachycardia cycle length, but for us was like similar and makes sense. It's could be like common science. His refractory PVCs, we think the third Holter ECG trace, the end or the last QRS complex, it's evidence of fusion and the cause for termination of the tachycardia. So in case we have his refractory PVCs, and this could be 3 possibility responses indicate more likely AVRT in absence of bystander accessory pathway in case even RT or AT. So it could be advance the atrial activation sequence without change the atrial activation sequence, or termination as VT without conduction to the atrium like in our case. Or it could be just atrial activation is delayed without change atrial activation sequence like in decremental accessory pathway. So we still think it could be Holter ECG, terrestrial, could be just PVC, history refractory, and without reach the A and terminated tachycardia. So in differential diagnosis, when we talk about narrow complex tachycardia, we have certain algorithms that we know in multiple guidelines. One of them, it's the European one. So when we talk about, in our case, was narrow complex, we think because it's aberrancy. So we have a narrow complex QRS tachycardia, less than 120 milliseconds, and it's regular, and A to V, it's 1:1, and RP tachycardia is still shorter than PR, but it's more than 90 milliseconds. So we think our differential diagnosis could be first EVRT, then a typical EVNRT, or focal atrial tachycardia. So because our, according to the Holter ECG analysis, we think it's the case is orthodromic EVRT. So about management for orthodromic EVRT, if we have absence of pre-excitation on resting ECG, so a drug medication treatment versus catheter ablation is still class 1 indication in both cases. Our patient is preferred to go to the ablation. So at this point, we conclude this case at that visit based on Holter ECG analysis. Properly, the diagnosis is atrioventricular reciprocating tachycardia through left side free wall accessory pathway. To confirm our interpretation, we suggest EP study. So EP study was, and ablation was performed 4 months later. And we see here in this EGM trace, narrow complex tachycardia, it's around was accurate measurement was 320, not 310 milliseconds. It's like the same tachycardia cycle length in a Holter ECG, and it's eccentric. And there was the airless in CS catheter 1-2. So we done there several maneuvers like overdrive pacing, and everything was more compatible with the EVRT than EVNRT. And we did also the history refractory PVC, and as you saw here, that it's advanced the atrial activation without change atrial activation sequence around 30 milliseconds. So talk home message here, clinical approach for SVT is still extremely important. Start with the history physical examination, ECG at rest, stress test could be useful. Holter ECG, like in our cases, was extremely useful. Could be adenosine test, accurate interpretation of Holter ECG, like we saw in aberrancy, history refractory PVC, could be Commel's-like sign, and differential diagnosis of SVT and management. That way I before mentioned from the ACS guidelines. Thank you.
Dr. Mustafa, a great presentation. It is a demonstration that the reading of a Holter recording is an ultimate test of the skill of the electrocardiologist. It requires a great deal of knowledge, subtle changes, the cycle length changes, the onset, the offset, and all that. Dr. Mustafa, would you please talk something about your mentor? Where are you getting trained?
Excuse me, our what?
Where are you getting trained? Who is your mentor?
So my mentor is Dr. Sham Menon. You know him, I think so.
Yes.
Dr. Shukumar Menon is my mentor in McMaster University, Hamel General Hospital. I'm second year there in the EPFL. I'm starting just the second year already now.
Absolutely great. I'm sure he's so very proud of you.
Thank you.
Dr. Malini, the Holter. It is just that one should be lucky to have this arrhythmia recorded during the Holter. So the longer you monitor, there are more chances. But then once you have that an arrhythmia, I think it's absolutely a test of your skills to read what it is, etc. Dr. Malini, your inputs.
Oh, I totally agree. I think a really nice job, Dr. Mustafa, in reading that Holter. Pretty much arrived at the diagnosis based on the features you showed. I want to pick up on one statement you had made about Kumel sign, and since you've done such a fantastic job interpreting the Holter, maybe you can tell us about this as well. So you mentioned that in the Holter, with the loss of left bundle branch block, the cycle length of the tachycardia shortened. So that made you think about perhaps an ORT using a pathway on the left side. So that's kind of the Kumel sign equivalent on the ECG. And then you went on to say, well, in Kumel sign, we normally look at the VA interval, not the cycle length. Now, in Kumel sign, you should be looking at both. But why did you say the VA interval is more reliable than the cycle length to determine if there is Kumal sign or not. I think that's a very nice point to make for the fellows on the call.
I think because when I just review, the old study about Kumal that he mentioned, his Kumal sign or Kumal phenomena there, they talk all the time about the VA time. He didn't mention really the tachycardia cycle length. It makes sense that when we have less VA time, the tachycardia cycle length should be less because we lost that septal conduction time there when the aberrancy is resolved. But he still just talk about the VA time all the time. It's more than 30 milliseconds about the left free wall axillary pathway, or less could be on septal axillary pathway. So this is why I mentioned just to not confused, because always we're talking about VA time, not the tachycardia cycle length.
Let's take it. That's very nice. That's very nice. Let's take it a step further. So let's say you lose left bundle branch block during tachycardia, right? You suddenly go from left bundle to narrow complex. And let's assume, like just in this case, you have a left-sided pathway causing ORT. So as you said, you lose that transeptal conduction time. So the VA time shortens. And you also expect when the VA time shortens for the cycle length to shorten as well. The reason it's not emphasized on the cycle length is because when you shorten the VA time going up through the pathway, the next impulse arrives sooner at the AV node. So you may have a little more decrement in the AV node. So AV time might lengthen a bit, and that might lead to a phenomenon where the VA shortens, but the cycle length doesn't shorten as much as the VA shortens. So usually you will see some shortening of the cycle length, but it may not be as much as how much it shortens with the VA. So the VA is a more reliable way of assessing the Kumal sign than looking at the cycle length. That's the reason the VA time is really emphasized in that. Is that making sense?
Yeah, of course. Yeah, I catch you. Thank you very much.
Perfect. Very, very good points. Again,
Thank you.
congratulations. I'll turn it over to Dr. Badwar.
Thank you.
Yeah, I mean, it's a very good example of using your surface ECGs and arriving at your diagnosis. And I think you rightly pointed out a few things. Can you go to the previous slide where you showed the initial? Yes, yes. So I think you really pointed out, whenever we do EP, we start with doing electrophysiology, everybody starts looking at EGM. And at our place, whenever the fellows present, I always tell them start from the surface. Otherwise, I tell them you're cheating. And when you cheat, you can go wrong. So starting from the surface really gives you all the answers, right? So like you rightly pointed out that this is wide complex, but it's starting with the P wave. It cannot be VT, right? The only VT that you can have is conduction system VT that starts with the P wave. So that is important. The other thing that you did not, emphasize, but it's important. If you always get an SVT that initiates by the presence of left bundle, that should always make you think that this patient has a pathway, especially a left-sided pathway, because it requires that left bundle for the pathway to go. Because usually when you have sinus rhythm going on, the node might be concealing, right? And so the pathway is not ready to take on. But once you get left bundle, you have enough time to now, because of transeptal conduction, to allow slow conduction to go through, and then the pathway is ready to receive and go retrogradely. So that is another point. And then, you showed towards the end the termination with the PVC, the third slide, which is also very nice. And you're saying that it's a fused beat, which would mean it's a V on his. But anytime SVT terminates or starts with the PVC, at least you rule out an atrial tachycardia. But as you rightly pointed out, the presence of, this is very, very important for other people, that this is a fused beat, right? It's not a pure PVC. So that would rule out that. And then the last thing you showed, show me your intracardiacs, where you showed the PVC pulling in the A. So that is suggestive that the pathway is present, but to be absolutely diagnostic, what you have to show is there is resetting, which means you pulled in the A, that should then pull in the next V and A. And if you show that, then it is absolutely diagnostic. Otherwise, it just says you have a pathway. But the other 2 points that you made, which was pushing out or terminating without going to the A, those are absolutely diagnostic. So I think it's a very good, you highlighted all these features. It was initially pointed out by Kumel. Hein Wellens showed that anytime you start an SVT with PVC and terminate with PVC, it's most likely a pathway. And he showed it in the lab also. He was the first one to show that in the lab. And this VA timing was proven by Kerr and Gallagher at Duke because they were the first ones to do EP studies in patients with pathways.
Okay.
Very good.
Thank you.
Very good illustration. And I think there is also, once you become an EP fellow, the timings of the prolongation of the VA time also tells you whether the pathway is free wall versus septal. And in your case, you show prolongation by 40 milliseconds, which would argue for a free wall pathway, which is exactly what you have, right? Your CS distal is early.
Yes, yes, yes.
Nitesh, great points. Malini, thank you so very much. I think Deep is also around. So now we invite the next speaker, Swasti. She is now conquering the summit, ablating the summit. Welcome, Dr. Swasti.
Thank you, sir. Is my slide visible?
Yeah, your slide is very much visible and you're audible.
Good evening, everyone. I'm Dr. Swasti, senior resident from Department of Cardiology, Sri Chitra Institute. My case is titled Ablating the Summit. Our patient was a 26-year-old college student, known case of hypothyroidism and rheumatic heart disease with mild MR. He presented with complaints of paroxysmal palpitations associated with pre-syncope fatigue for 3 weeks duration. He was evaluated at an outside center and diagnosed to have recurrent PVCs with runs of NSVT and VT. He was later referred to our center for further management. So this was the ECG of the patient at presentation. The ECG showed multiple VPCs with runs of NSVT. The VPCs are of RBBB morphology with an inferior axis, negative in 1 and AVL with positive concordance in the chest leads, early transition, indicating that possible origin is from the left ventricular outflow tract, possible locations being the left coronary cusp, aortomitral continuity, or the anterolateral mitral annulus. LV summit also cannot be ruled out. The echocardiogram of the patient showed dilated LV with global LV hypokinesia and moderate LV dysfunction, indicating that this was a long-standing process. The LV dysfunction was likely secondary to the tachycardia-induced cardiomyopathy. So given the significant symptoms of the patient and LV dysfunction, the patient was taken up for EPS-RFA under 3D background. So the basal study showed ventricular activation during VPC was earliest at CS1-2. So we had placed the CS catheter very deep in because we were suspecting origin from lateral areas. First, we decided to go ahead with the endocardial approach. The ablation catheter was placed via the retrograde transaortic approach, and initially it was placed at the LCC and activation mapping was done. The signal at the LCC was only 32 milliseconds earlier than surface ECG. So this was not a good signal. So next, we started activation mapping at the aortomitral continuity. The local near-field EGM was earlier than surface QRS by 42 milliseconds. We were getting a good signal. However, the unipolar EGM showed a small initial R wave pattern. So this was likely not the site of origin of the VPC. Radio frequency ablation was done at 35 watt power at 43 degrees Celsius. The PVCs got suppressed in 15 seconds and pulses were given for a total duration of 60 seconds. However, there was recurrence of PVC. This is the EGM showing early far field signals on endocardial mapping at the AMC. The signal was 42 milliseconds earlier than surface QRS. So as the endocardial approach failed, secondly, we tried a different approach through the coronary sinus. So in the picture on the left, I have depicted the LV summit. The LV summit is a triangular epicardial space which is bounded at the apex by the left main bifurcation And the base of the triangle is formed by an arc which is drawn using the using the distance from the left main bifurcation to the first septal perforator as the radius. So as we can see in this picture, the LV summit is traversed by the anterior interventricular vein, which continues as the great cardiac vein. So the great cardiac vein divides the LV summit into two parts. The area that is marked by the red asterisk is the inaccessible area, or the triangle of Brocken-Moschow. So it's inaccessible because epicardially also we can't access it because it is covered by a thick fat pad, and also because of its proximity to the major coronary vessels like the left main and proximal LAD and LCX. The area that is marked by the green asterisk is the accessible area. It is our area of interest. To access this accessible area, we'll have to place the ablation catheter in the coronary sinus quite deep in, so as to reach the junction of the AIV and the GCV. So in the cine images, we can see that we are trying to maneuver the flexibility catheter in the CS in order to reach the AIV GCV junction. However, this was not possible. So in the second image, we have done a coronary angiogram, and it is seen that the ablation catheter is quite far away from the LV summit. In the third image also, we can see this is the LV summit, and the ablation catheter has not yet reached the LV summit. This is the pictorial representation of the same. This is the ablation catheter, which is very far away from the LV summit. And the signal that we got also was only 20 to 28 milliseconds early. So we did not attempt any ablation at this area. So we attempted to place a 5 French non-irrigated catheter, and we were able to maneuver it deep into the coronary sinus to reach the AIV-GCV junction. And this is the area where we got the earliest signal, which was more than 50 milliseconds early. And also we got a good QS pattern in the unipolar EGM. However, and in the cine and in the angiogram image, we can see that the ablation catheter has reached the LV summit. It has reached the LV summit. So multiple angiograms were done to ensure that there was a safe distance between the ablation catheter and any coronary vessel. But the problem that we faced here was that because we used a non-irrigation catheter, power delivery was limited because of the rise in temperature. So here, this is the EGM showing the signal that was 52 milliseconds early. And with the ablation catheter placed deep in the CS, at this location, we got a good unipolar signal, and ablation was done at this site. However, the power delivery was not adequate and the ablation was not successful. The VPC could not be terminated. So though we were not able to terminate the VPC, now we got a good idea where the VPC was originating from. So using the CS mapping with the earliest signal as the vantage point, we re-attempted the endocardial approach. So as we can see here, we placed the ablation catheter very close to the site where we had ablated when the ablation catheter was placed in the coronary sinus. So this was our initial ablation site. We placed the ablation catheter very close and parallel to the epicardial site, and RFA was done here with a power of 35 watt and temperature 55 degrees Celsius. And the PVC got terminated in 15 seconds. So this is the EGM showing the signal that we got at that location. The signal was 46 milliseconds early. Good pre-potentials were present, and the VPC was successfully terminated. So this is the post-procedure ECG, which is not showing any VPCs. So LV summit VPCs account for 12 to 14% of LV ventricular arrhythmias. The ablation of LV summit is one of the most challenging problems that electrophysiologists face due to its inaccessibility, complex anatomy, and proximity to coronaries. Ablation can be done through the aortomitral continuity, left coronary cusp, pulmonary trunk, coronary venous system, left atrial appendage, or the epicardial route. The take-home messages from this case are that in all cases of LV summit VPCs, a meticulous mapping of all nearby areas should be done. And the earliest signal need not be the most optimal signal, because many a time, even if we get the earliest signal at a particular area, we are not able to ablate at that site because of its proximity to vital structures. And even if ablation is not possible at the earliest signal obtained by epicardial mapping, they may be used as vantage points for delivering energy to such deep-seated structures. After all these measures, if the ablation still fails, some rarely tried options are bipolar ablation, coronary venous ethanol infusion, and needle RF ablation. Thank you.
Dr. Swasti, great case. Again, as a demonstration of how the summit PVCs can be challenging. They can be as challenging as climbing the mountain Everest, but then you succeeded. The vantage points. And I think if that was not successful, I think you would have gone for a bipolar ablation.
Yes, sir. That was
Dr. Malini. Over to you, Dr. Malini.
Fantastic case. Yeah, I do want to emphasize the proximity of different structures in this area. So I agree with everything that you had mapped and mentioned. Usually, at least a little bit of mapping in the RVOT can also be helpful just to make sure that you know exactly what is earliest, but this is very good. So when you think about what we call LV summit area, it's actually very thick ventricular myocardium. So when you get this earliest activation going into that AIV GCV junction, and there is a little bit of slurring of that EKG that you showed as well. So a little bit of that pseudo delta pattern, and the earliest activation looks like it's more towards the epicardial surface. It's still important to look on the endocardial surface because the corresponding endocardial surface to that AIV GCV junction is just beneath the left coronary cusp and just lateral to it. So if you look at that region with ice, you will find that it's a really thick portion of the myocardium. So if you go back to your slides where you showed the very last electrogram where you had ablated endocardially, I think that second PVC is very, very interesting. Would you be able to share that slide again?
Yes, ma'am.
Thank you. So you see there are two PVCs, right? They look exactly the same, but the first PVC, if you look at that RF distal catheter versus the second PVC, there's definitely a change in what the electrogram looks like. So you have labeled as a spree potential. Perhaps I would have called it a slightly far field potential, a little bit of terminology difference. Spree potential is usually used for when you have a sharp signal, a little bit of isoelectric line, and then another electrogram that would be a pre-potential. But some far field potential appears on that second PVC. So kind of again goes with the idea that this origin of this PVC is perhaps slightly further away from where you're mapping, but high energy of ablation at the site can sometimes be successful, not always. So certainly a very, very good point to make that you made about mapping all of these sites before you decide where to go and ablate. So having that idea, having that coronary angiogram proximity to the coronaries really helps you make that decision. Very rarely we have had patients where all of this kind of doesn't help, and you can do coronary venous alcohol ablation. So that would involve actually doing a venogram of the distal coronary venous system. So you can use a balloon occlusion catheter to do that. Really define what that AIV GCV junction looks like. And there's usually small veins that penetrate that region. And if you are lucky, you can potentially place a mapping wire distally into one of those veins and see if you get an earlier signal. So a little bit of unipolar mapping at that site, and then deciding is it useful to put coronary venous alcohol ablation in that area. So that's another thing to keep in mind. If you're really having trouble with these cases, you have done your endocardial ablation, epi mapping, potentially epi ablation if it's not too close to the coronaries, still not getting success, then this type of venous ablation can be helpful. I'll stop with that. We'll hear from Dr. Deep and then maybe Dr. Badwar after that.
Yeah, nice, very nice presentation, Swasti, and great mentorship from your professors at your stage in your career. It's great that you have been able to present this particular case and understand all this. Yeah, having intracardiac echo really helps, would make you understand the anatomy much better and appreciate the adjoining structures. so that whatever the understanding of anatomy you have from textbook, if you happen to see them live, and then it helps you to understand where all you could visit. And as Dr. Malian mentioned, it's a very thick portion of ventricular muscle just beneath the left coronary cusp. And then you understand why do you ablate in the left coronary cusp, and what duration you need to ablate to give the lesion to reach that particular muscle. And all those things you get to understand if you do eyes. Unipolar signals at this particular point would be very useful to understand as well. You have shown the bipolar signals, RF distal and proximal. It would help if you had the unipolar as well at this particular point. It would be there on the, I understand you did use the three-dimensional mapping. The three-dimensional mapping would have
Unipolar
the,
was recorded in the 3D system.
yeah, it should be having that particular information. Nothing more. Again, there are various ways of getting to these summit PVCs. Step 1, 2, 3, 4, 5. So we have it's usually a conference topic where we discuss what are all the ways we can ablate this particular one. I think you have listed all of them. Thank you.
Excellent. Nitish, anything more you would like to add? Nitish, you are muted, Nitish.
Yeah, sorry. Can you hear me?
Yes.
Yeah. So very nice, illustration of your stepwise approach. I just want to highlight a few of the things you did, which I really like. So if you show me your fluoro image, but first of all, we can start from this slide. So, outflow tract PVCs are the most common idiopathic PVCs, right? I mean, I generally call them outflow tracts, so you can include everything, summit, RVOT, LVOT, aortic sinus of Valsalva. As you rightly pointed out, right bundle branch block means you don't have to map the right ventricle, right? So you did good job. You don't. When it is left bundle, then you have to do all of that, as Dr. Malini was pointing out. Now, the other thing is when you have outflow tract, you look at lead 1. So lead 1, if it is negative, then it's going to be lateral. Lead 1 is positive, it's going to be septal, right? There's a big difference in these. Now, the other thing you didn't show here, but I don't know if you measured the MDI. MDI is very helpful. And if MDI is more than 0.55, this was published by David Wilbur in idiopathic PVCs and VT, and he showed if it is more than 0.55, MDI is in the precordial leads, you go from the onset of the QRS to the peak divided by the total QRS duration. If it is more than 0.55, it points to an epicardial origin, which means you're not likely, that is where it is coming from, but you're not likely to get it endocardially. Though now we have, as you have shown, you have to develop these techniques. And then I want to see that image that you showed of the coronary sinus. So show me the image that you showed initially. I like the fact that you put the coronary sinus catheter from above, from the neck. And that is what I do. Most people in US, they put the coronary sinus catheters from the groin. And one thing that could help you is I see you have I think you have a 6 French coronary sinus catheter. This does not have a lumen in it. If you use a 7 French coronary sinus catheter, it has a lumen in it. You can put a wire through it, like a whisper wire. You can use, we have a micro 2 French mapping catheters available. You can get those. They have multiple electrodes on them. So then you can put it very distal. Sometimes the catheter won't go, and then you can cannulate. You can start off by doing balloon occlusive venography and seeing different branches. And if you know it is lateral, you would be heading towards a lateral branch. And that microcatheter will give you the timing. You might not be able to inject alcohol there because in lateral veins, they are very big. The septal ones are easier to do because they're small veins and you go into the septum. But it will give you a vantage point right from the beginning where you're going to target. And then you would do the same steps that you did, which is you try initially to go distal into the coronary sinus as far out as you can. The advantage is it is protected. The veins, the muscle sleeves of the veins are protecting you from damaging the left main and the LAD. So that is the best way to do it. But if you can't, then you try the approach that you did, which is go to the LVOT and try to get as close to it based on your 3D map. If you didn't have a 3D map, having a 2 French or a small catheter with which you can record the signal would have been your guide. And then lastly, the other thing that works is if that doesn't work is doing the bipolar ablation. and which means you have to go somewhere from the left ventricular outflow tract to the pulmonary artery or to the catheter in the coronary sinus. And last thing is some of these can be very thick. This area is very thick, and no matter what you try, this will not work. In that case, you have to have the surgeon go there epicardially and lift up sometimes the coronaries and ablate over there because the tissue is so thick you can't get to that. But it's a very nice stepwise approach, and I think how you approach it, how you use the ECG, but always remember in the ECG, lead one will help you, septal versus lateral, and which vein to cannulate and which way to inject alcohol if you need to.
Great points, Nitish. Very few centers in the country, they're kind of equipped to deal with these.
Ullas, can I make one comment?
Yes, sir, please.
I know I'm being, I know you're running late of time. Two quick comments. One, your successful ablation site was not the earliest activation site. I noticed it was 46 and somewhere you had 52 where you were unsuccessful. Comment on that. That does the earliest activation not necessarily be the success and little later be? And second, 15 seconds. I always think that any substrate for ablation, if it doesn't go within 3 or maximum 5 seconds, you have high chance of recurrence. Do we have a Holter or intermediate term follow-up in this patient?
Sir, on follow-up, the Holter VPC burden was less, around 1 to 2% only.
So Yash, can I make a point about the question that you were asking? The issue is you are right. They are not at the site, but nobody knows where the site is. It is somewhere deep in the septum, in the summit area, right? And you just can't get there. The best way to get there is to perforate the septum and or the mid myocardial part of the heart and then take a thing and go around there. But we don't have the technique to get there. The needle ablation was designed, but it is gone. It doesn't work. It has a lot of complications. So in this case, if she told me it went away within 5 milliseconds, that means she was sitting epicardially right on top of that. Then I would worry that the coronary would be damaged. In this case, I think the best solution is this. It will take time because you are approaching it. You have to understand where you're trying to get. And this is why the other case was to use the ultrasound. The ultrasound really shows you where there is a gap. We call it the interleaflet triangle, in between that there is a small space where you can enter and deliver energy, but it takes time to deliver that. And so you have to use 35, 40 watts and wait for, you have to give long lesions because it has to go through that area. You're not sitting on top of that.
Great points, Nitish. Very few centers in the country are equipped with dealing these kind of LV summit. Not many centers have these micro catheters for mapping. And I really wish that whenever we are looking at these so-called LVOT-VTs, and if you are looking at the lead one and the MDI, and if you have a great suspicion or possibility of this to be LV summit, I think we should take pause and then have all those gadgets inside your laboratory, and then only you should proceed. Because what is happening is only in some of the centers, because this is there, we do this LV summit PVC ablation more often than the usual LVOTs, only because these are the failed cases, because of the non-availability of the mapping. And somebody has quoted in the chat, Malini can come into the discussion here. If you have pushed the 5 French catheter too deep in, there is a way of getting that adequate temperature and the power. If you also have a small RCA catheter and going on pushing the saline, these are some techniques, but you require, I think, little expertise and more experience. How do you, with the available tools, like 5 French ablation catheter deep in, how do you achieve the power? Is there any way of achieving?
Yeah, I think a non-irrigated 5 French, it would be very difficult to create a sufficient lesion with that. Even if you try to irrigate from somewhere else, some other catheter next to it. So that wouldn't be ideal for this situation. I think a venogram might have provided a roadmap as to whether the veins are truly non-accommodative of a 8 French catheter. Usually they aren't. It's just usually you're kind of stuck in some small branch and you have to release yourself to kind of get to that spot. I agree that that kind of 2 French mapping catheter may not be, universally available. Another thing that you could do is, typically we have a variety of angioplasty wires available, right? And some angioplasty wires have a tip that is not insulated. So one wire that we use is called the vision wire, and there might be an equivalent of that in India that could be looked for. So you can put the angioplasty wire in there, provided the tip isn't insulated, and then really record like a unipolar electrogram from it. So you have to put it through some kind of catheter, like a multi-purpose catheter. So most of it is insulated, and then just the tip is in your area of interest, and then you put a alligator clip to it, and it actually does give you unipolar signals. So that's another thing to think about if you don't quite have that multipolar 2 French or 4 French catheters to push into the vein. Usually having a roadmap really helps, so that occlusion venography, especially if you do it from the neck, you get some really good images, good roadmap to where you need to be for this. One more comment on like looking at the lead 1 to determine where you want to go and map. So in this particular case, lead 1 had a small R wave and then a very deep S wave, right? So that doesn't rule out a slightly more lateral exit to the PVC. So the time when you have a completely QS complex on lead 1 is if you're completely lateral and epicardial for your exit. So there is no other myocardium to activate to the lateral wall beyond that. So that's when you get a completely QS complex with like that MDI that Dr. Badwar is describing being like 0.55 or higher. But if you have like an endocardial exit on the lateral wall, or if you're slightly lateral, like the AMC beneath the left coronary cusp, you're still not septal, you're still kind of towards the lateral wall, you would still have a small R wave because there is still a lot of LV myocardium lateral to you that gets activated. So small R wave and the deep S wave can still be seen. So the only time that really works out is having a completely negative QS complex would be an epicardial exit on the lateral mitral annulus. So that's another thing to keep in mind. Really helps you know whether you should be mapping more laterally or coming more towards the GCV AIV junction.
Thank you, Dr. Mali. There are 2 things. When it comes to the mapping, a 4 French multi-purpose catheter and a coronary wire deep inside, only exposing the tip, has helped us several times. And a 5 French ablation catheter deep in and proximal to it, wherever it goes, a balloon occlusion CS catheter and injecting continuously some saline had helped us to achieve a greater power. These are the 2 techniques which we have used. But ablating summit PVC is going to be challenging. I think it exposes the lack of the tools which are available. We require a smaller profile ablation catheter which are irrigated. I don't know when do we get them, and we hope we get them soon. A great input. So we'll call the next speaker. This is going to be the last presentation for the first day of the summit. Dr. Yannick.
Hello. All right, let me just load up the slides here.
So you are
Nitish's
protege, huh?
That's right.
Yeah.
Am I visible? Slides look good and audible?
Absolutely, absolutely.
All right. Well, good evening, everybody, or in my case, from California, good morning. My name is Yannick Desai, and I'm a first-year electrophysiology fellow at Stanford University here in California. Thank you so much for the opportunity to present this case at this really spectacular conference. I've learned a lot already so far. I am presenting a case that I performed with my mentor, Dr. Nitish Badwar, who I feel very, very lucky to train under. The case is titled An Irregularly Irregular Rhythm Misdiagnosed by an Apple Watch. So as noted in the title, this case starts with a misdiagnosis. We have a 51-year-old woman. She came into clinic and she said, I have had an intermittent history of palpitations for the last 20 years, ever since I was in my early 30s. And she has an Apple Watch, and she actually came to clinic with a tracing from her Apple Watch, which I've shown on the right side of the screen. Now, this tracing was interpreted as atrial fibrillation. And just looking at it, I certainly would have thought that would be a reasonable conclusion from this single strip. You see an irregular narrow complex rhythm there. So she was actually referred to us for an EP study and ablation. I'll tell you a little bit more about her history. She has no other really significant medical history or cardiac history. She had no evidence of cardiomyopathy on echocardiography. She has no family history of any arrhythmogenic cardiomyopathy or early onset atrial fibrillation, and she's not an extreme athlete or anything like that that would predispose someone to early AFib. Again, she was noticing these palpitations in her 30s. In the EP lab, she has a 12-lead EKG at the beginning of the case, which you can see here, which again redemonstrates now on a 12-lead an irregular tachycardia. So one of the fun things about electrophysiology is that we're always solving mysteries. Dr. Badvar has repeatedly instilled in me and his fellows to think like Sherlock Holmes, to think deductively. So we have a healthy woman. She doesn't have any cardiomyopathy. She's not an extreme athlete. She had no family history of early onset AFib. And yet she's reporting 20 years of palpitations associated with this highly irregular rhythm. So something doesn't quite fit. And before we commit her to a diagnosis of atrial fibrillation, she was actually already on anticoagulation, if I'm not mistaken, let's consider whether there was an alternative diagnosis. And this was the benefit of the intracardiacs. So we brought her to the EP lab for an EP study. And we noticed very frequent, almost incessant, spontaneous initiation of her tachycardia, which is shown here. So on the top, we have our surface. Sorry, it's a little blurry here. I've blown it up, but we've got the surface on the top. Then the next three channels are the prox, mid, and distal His channels. And then lastly, the CS prox channel to distal channel. I want to emphasize a couple of points here. The first is that the tachycardia has a very short RP interval, or really the A's and V's are right on top of each other. So we call this an A on V tachycardia. And the other thing to note again here is the considerable amount of irregularity in the tach cycle length, or in other words, the wobble. So we saw this on the 12 lead, and now we're showing it in the intracardiacs as well. And I'll note that that wobble continued not just on the very beginning initiation of the tach, but continuously. So whereas we were previously presented with possibly what looked like AFib, now we are faced with an A on V tachycardia. And when I think about an A on V tachycardia, I note a differential of 4 diagnoses typically. Those diagnoses most commonly are typical antegrade slow, retrograde fast AV-NRT. That's the most common A on V tachycardia. But we can also consider atrial tachycardia with a very long PR interval. And then a few tachycardias that are much rarer in adults. In our practice, we're mostly treating adults. So junctional tachycardia, which we often think of as more of a pediatric diagnosis, but occasionally can show up in adults. And then much more rarely, an atypical bypass tract. So a notoventricular bypass tract with only retrograde concealed conduction can also present with an A on V tachycardia, though again, that is quite rare. Now, a priori, if you showed me an A on V tachycardia that was really irregular, I would be postulating or thinking about a focal etiology, something like a JT or an AT. So again, we're going to start thinking about our maneuvers, but just from what we have so far, start building a case, using our clues and thinking deductively to what possibly the diagnosis would be. So now I'm going to show you a strip that showed the onset of the tachycardia. Here, I'm showing proximate and distal hiss here on the bottom, as well as the surface electrocardiogram on the top. You'll notice that on the left side of the screen, we've started in sinus. Here's the AHV. And by the right side of the screen, we're back in our A on V tachycardia. And you can see that we have several PVCs in the middle of the screen. So we're starting to, again, build clues about what the mechanism could possibly be. We haven't proven anything yet. We mentioned junctional tachycardia, and I'll just make a comment that, as I said, it's generally considered much more of a pediatric diagnosis, particularly junctional ectopic tachycardia, JET, which is thought of as a rhythm due to enhanced automaticity. JT much less common in adults, but when it does occur in adults, thought to have perhaps more of a triggered mechanism. So again, as we build clues, maybe the fact that we're seeing this highly irregular A on V tachycardia that is initiated by a string of PVCs, maybe there's a triggered mechanism here. Is this JT? That's kind of what we were thinking as we proceeded with the case. So I'm going to show the same phenomenon of initiation. Again, on the left, we're in sinus rhythm. Now we've got the coronary sinus channels available as well. And by the right of the screen, we're in the A on V tachycardia. And we note here that we have a PVC that initiates the tachycardia with a V. This is the PVC, the V, A, H, V initiation, followed by the irregularly irregular tach. So take a moment to kind of ponder this initiation, which is already starting to rule out some of the diagnoses on our differential that we talked about, which we'll revisit at the end. I want to show another phenomenon that we observed during the tachycardia. So here we're in the tach from the beginning of the slide, all the way on the left and throughout. And there are several PVCs that interrupt, that are in the middle of the strip. And despite the PVCs, the tach continues. What we'll note is that the PVCs are actually dissociated from the hiss. And I think this is most clearly visible in this first PVC. The hiss is denoted by these blue arrows. It's a little difficult because there's some wobble, but our argument from this slide is that the PVCs are dissociated from the hiss, which march straight through. And our interpretation of this is that this argues that the ventricle is not part of the tachycardia circuit, which again starts to rule out some of the diagnoses on the differential that I initially presented. Next, I want to show the spontaneous termination of the tachycardia. Again, on the left, we're in the tach. And in the end, we see that we terminate with a V followed by an A, so ending on an A. This suggests that the block that terminated was at the level of the AV node, which again gives us some clues as to the diagnosis. Next, we were back in the tach, and we demonstrated ventricular overdrive pacing at a drivetrain of 420 during the tachycardia. And what we note is that we have a VAV response as the tachycardia continues. Now, the next slide here I want to show is that, again, we're in the tachycardia. We're in the A on V tachycardia. And then at the right of the screen, we see that we're in sinus. And in the middle, we have a maneuver here that led us to termination of the tachycardia. So we see that we're actually doing AOD, atrial overdrive pacing, at a drivetrain of 400 milliseconds. We're pacing from the coronary sinus here in the atrium. Now, the red arrow that I've shown here is the first paced atrial beat. And what you'll notice it does not affect the immediate hiss indicated by this blue arrow. It does not, this paced beat does not affect the hiss, which comes on time. And the idea here is that this hiss was already committed by the antegrade wavefront of the tachycardia from the preceding beat. So at this point, with this beat, if you look closely, we've actually already terminated the tachycardia with this beat, and the rest of the beats we are pacing AHV with a fixed AH interval. So this beat, this single atrial late PAC has terminated the tachycardia. A late PAC that terminates the tachycardia without affecting the immediate following hiss has been published. This maneuver has been published to show that you have disproven JT with this maneuver. So let's put it all together. We had an A on V tachycardia. We noticed initiation with a single V and a VAV initiation. Then we showed VOD during the TAC with a VAV response. And then we showed a spontaneous termination with an A, which together ruled out atrial tachycardia. Next, we showed dissociations of the PVC of the vent from the His, showing that the V was not part of the circuit, ruling out this rare diagnosis of concealed notoventricular tachycardia. Lastly, we showed initiation with a single V and termination with late PACs, arguing against junctional tachycardia. And so we were left with typical AV NRT as our most likely diagnosis. At this point, we proceeded with ablation of the slow pathway. Here we were ablating in sinus rhythm, which we begin with on the left side of the screen. And towards the end, we see slow J's during ablation. And at the end of the case, the patient who initially came in with incessant spontaneous initiation of the TAC was no longer inducible for the tachycardia. So I'll return to our old friend Sherlock Holmes. We have a case of a highly irregular rhythm, which on 12 lead looked very convincing for AFib, but proved on intracardiacs to be typical AV-NRT. We know that AV-NRT can have some irregularity on initiation, and others have described longitudinal dissociation in the AV node, showing 2 fixed intervals within an AV-NRT tachycardia. But a completely irregular AV-NRT has not really been described as far as we are aware. And I think this shows us that despite all the progress we have made in understanding the AV node, it continues to be kind of a vexing black box to some degree. But with that, I will conclude.
Dr. Yannick, fantastic presentation. You really spoke like your mentor Nitish is speaking, the master of A on V tachycardia. Whether it is regular, whether it is irregular, whether it is irregularly irregular, whether it is 1:1 AV. Man, you know what? Your presentation is a great tribute to your mentor. Absolutely stunning. And I'm going to be going on through your presentation one more time through the night. All right. So, Nitish, another gem you have produced. Let's start with you only.
Thanks, Ullas. I think Yannick did a great job. I think it's self-explanatory that we have to be, I think the 2 illustrative points for me, for the trainees and fellows is always take a history. Not every atrial fibrillation patient has a different history. And sometimes people just, brush it off. There is documented, even if this patient had ECG, it would look like AFib, right? And the Apple Watch is not making a mistake. It's just using its algorithm. Unfortunately, many people just use that and would have taken her to the lab and done a pulmonary vein isolation. And Yannick has published earlier with me where we showed a patient with double fire who had PVI done and came back to me from somewhere else and came to see me and had just had double fire, which was causing his symptoms. So that is important. That history is very important. Somebody giving you a history of 20 years of palpitations in a young person, she's 51 years old, you should always do EP study with conscious sedation before doing, because if you did general anesthesia and pulmonary vein isolation, you would not get it. And then the second thing is really just paying attention to the maneuvers in the lab. So that is all I wanted to illustrate.
Dr. Malini.
Really fantastic case. Thanks for sharing. I don't have too much to add, but I want to pick your brain, Dr. Desai, and also Dr. Badwar. about what is the, it's very rare to see this amount of wobble in AVNRT, right? You might see a little bit, you might see a few beats wobble, but usually it settles down and it's usually a very stable rhythm. And most of the wobble is happening kind of in the AH interval. So just kind of, your thoughts when you looked at this as to what the mechanisms are and what to think about when you see this.
I'll certainly defer to Dr. Badwar, but I agree. I mean, my understanding in general is that the wobble is in the antegrade fast, antegrade slow in the AH interval. But, I think Dr. Badwar, we were postulating, is this some kind of true longitudinal dissociation in the compact AV node, in the circuit? Is that what this suggests? I don't know.
I think from my perspective, it just makes a point that there is no real pathways present in the AV node. There is some reentry happening deep down in a black box called the AV node, which nobody can go in and map. And these are just breakouts. And there is nothing more illustrative of this than that. And, this is what Mark Josephson used to say. I remember, learning from him. And it is absolutely, perinodal tissue is what we use to ablate AVNRT, but really the reentrant circuit is a very small, deep inside circuit. I mean, to me, if I see something like this, most people would presume, and I presume this was junctional tachycardia, till you start doing diagnostic maneuvers. So it is very important to do that. And in junctional tachycardia, sometimes you ablate there, but the ablation strategy is a little bit different than AVNRT.
Deep, you want to make some comments?
Yes. So even if in this case the Apple Watch was right, if it was even atrial fibrillation in a youngster, as it was rightly pointed out, it's important not to take the patient right away for a pulmonary vein isolation. So we have had patients referred for PVI, such patients referred for cryos, telling that AFib's recorded. But then you do the EP study, we find out concealed pathways, AVNRTs, and in which case you just do them and then put them on Holter subsequently and find out they don't get any more of these things. So triggers of AFib could also be SVTs.
Absolutely.
Yeah.
Yes. So AFib ablation, preceding to that, a detailed electrophysiology study is important. That's what it is. All right.
Ullas, I want to trouble you for one last comment.
No, sir, you trouble us forever.
So, Yannick, that was a masterly presentation, worthy of an electrophysiologist rather than a fellow. I'm sure all will agree with me. And if you see,
much credit to Dr. Badwar.
I think you showed Sherlock looking like Nitish, or Nitish looking like Sherlock. and if you continue with Nitish, you are headed for great things in electrophysiology.
Absolutely.
We have just wanted to make a last comment with Vaibhav Vaidya. We have 3 cases which have been accepted in JAC, AVNRT masquerading as AFib. So I think it's more common than what we think. Wobbles are much more common, or at least not as rare as we think. Thank you.
Dr. Yash, I'm sure you agree with me. Today was great learning, 13 wonderful presentations. And, I thank all those presenters, absolute great presentations. And, they have put in so much of a effort and their passion was very much evident. And at the same time, I would like to express my gratitude to the moderators. They are all, I'm sure all those attendees today, they agree with me. They are the best of the minds in the electrophysiology. And, I am fortunate that I heard all of your presentations and I wish that you also had learned something and you derived some inspiration. So we are again joining a week later on 31st of August for the second day of this EP Fellows Summit. It was great learning for me and I hope all of you too have learned and gained some inspiration. So thank you, everyone. Yash sir, it's so touching that you were here, and the last comment also had to come from you. Wonderful. So I wish, sir, the next week also you would be joining us, Dr. Yash.
Of course.
Yeah. So Dr. Malini, Nitish.
Ullas, when Edward Rowland had come to KEM Hospital in 1997.
Yes, sir.
And we were doing EP cases in the evening.
Yeah.
And the BARD people told him, sir, there is a dinner at the Taj, at about 9:30, 10 p.m. when we were starting our last case. And Edward told them, but this is dinner. This is dinner with dessert.
Yes. So, Dr. Yash, I look forward to your participation in the next week too. Deba, I can see you. See here, this guy again going to do ablation, I think now. Okay.
No, you're not.
All right. And
Done.
Nitish, you look rock star.
Thank you, sir.
Sherlock Holmes.
Yes.
All right. So thank you, everyone. It was wonderful. And see you next week. Bye-bye.